So ma'am, be ready. We have a minute left to go live. I'll be giving count.
Okay.
Good morning to you, Mr. Bajpai.
Bajpai sir, you are on mute.
I'm not on mute, but probably they are giving.
Yes, you're now.
No, sir, good
Okay,
morning.
sir. I'm giving count.
Please, sir,
Are you ready,
good
sir?
morning.
Yes,
Sir,
you
are you
can
ready?
start.
Ma'am, just speak something. I need your view.
Yeah, I'm
Should we,
ready.
ma'am? Yeah, okay. 5, 4, 3, 2, 1. You are live, ma'am. Go ahead.
Good morning, everyone. I am Shubhi Dikshit, an event coordinator at Institute of Medicine and Law. I am delighted to welcome you all to the 8th National Convention on Medicine and Law 2023. This is a prestigious event that brings together experts, practitioners, and policy lawmakers from the field of law and medicine to discuss and debate the issues related to healthcare. The topic of this year's convention is privileging in medical practice, need for a quick action. We have an exciting lineup of speakers, panelists, and moderators who will share their insights and experiences and perspectives on today's topic. We hope that this convention will be a fruitful and enriching experience for all of you. I welcome all of you once again. Thank you for joining. We look forward to your active participation in the convention. Thank you so much. Over to you, sir.
Thank you, Shubhi, for that wonderful welcome note. Good morning, dear esteemed panelists and all our online viewers. On behalf of the Institute of Medicine and Law, I welcome you to this 8th National Convention on Medicine and Law 2023. For the past 7 years, we have been raising some contentious legal issues that are faced by the healthcare providers and affect patient outcomes. Since this convention deliberates on these issues with all the relevant stakeholders, that is, the healthcare providers, the policymakers, and the legal professionals, besides the lawmakers, that is, member of parliaments, more specifically, those who are doctors themselves. We also have patient bodies, NGOs, and others. We are not only heard seriously, but our sincerity and our efforts are well appreciated, and we are growing with each passing year. This year, we are trying to raise a legal issue that is probably still in its infancy, or rather, to put it bluntly, except for a few handful, no one even knows that such a problem exists. But it is certainly causing problems in the way healthcare is being delivered in this country. And going by the experience of other developed nations, this could be a serious cause of concern for us in the near future. And hence, the need to discuss this important topic. I am referring to something we know in medical parlance as privileging. Not only lawyers, but even doctors and hospitals, the ones who should be implementing it or following it in their day-to-day practice, are not very well conversant with this concept. When I speak with my doctor friends, I find that it is often confused with credentialing, which is primarily based on the qualifications of the healthcare provider, their degrees and their diplomas. The universally accepted definition of privileging is, and I quote, privileging is a doctor's capability to perform specific skills and procedures and provide patient care services consistent with his training, experience, and qualifications. The regulator of modern medicine, the National Medical Commission, has probably not been able to give due importance to this aspect of medical practice. And the courts are taking inconsistent views on this issue. The National Consumer Commission has recently gone to the extent of directing the regulator to make guidelines on this aspect. In a country like India, where scarcity of doctors, the existence of quacks, and the urban-rural equality in healthcare services is a stark reality, should we really give importance to privileging? Is the bigger question before this convention today. And what should be the contours of the laws, the regulations, and the guidelines that will help in making our society healthier is perhaps the smaller question before this August forum. With these few words, I request Dr. Shivkumar Utture, the convener of today's session, to formally announce the session open. Dr. Utture needs no introduction. He is a man with many hats, a surgeon, an agitator, a leader, an orator, and also, on the other side, a part of the regulator. He is a former member of the National Medical Commission. He is the president of the Maharashtra Medical Council and the vice president of the largest body of doctors in India, the Indian Medical Association. I would also like to request Dr. Utture to share his own thoughts on the subject before we proceed further. Over to you, Dr. Utture, sir.
Yeah, thank you, Mangal sir. And at the outset, I think I must congratulate IML, Mangal sir, Bajpai sir, and of course my very good friend, Dr. Parag Rindani, for and plus all these luminaries who are there for taking up this issue, which I myself have been handling as the president of the Maharashtra Medical Council. Incidentally, I have finished my tenure as the Maharashtra Medical Council after almost 10 years. So basically, this question has been asked to us at all levels, not only at the council levels, but as Mangal said, that it is there at the consumer level, it is there in the criminal courts of which doctor can do what practice. And this is something which I think has to be tackled. And it is high time the councils take up this issue and make some rules and regulations as far as ethical aspect is concerned of privileging, so that, there's no ambiguity, because we find over the years when we are seeing different judgments coming out from different courts, they are so opposing each other. So it becomes very difficult for the medical fraternity to exactly, do what is legally right. And of course, the aspect of morally right also comes into play in this issue. So therefore, I think I see a lot of legal luminaries, respected doctors, policymakers, and of course, honorable judges who are there in this esteemed group, who will be giving their thoughts on this very, very important aspect. And I think which will be taken up by the National Medical Commission also, since now even the courts have asked them to make these rules and regulations. So I have been asked with not only with the opening remarks as the convener, but also as far as my thoughts are concerned, as far as this issue is concerned. So with your permission, I will just do my screen sharing. Yeah, can you see my screen, please?
Yes, Dr. Utture, it is visible.
Yeah, thank you. So when we talk about this very, very important aspect, so what is happening over the years is, since specialties, super specialties, and super specialties are there, so coming up day in and day out. And jokingly we say in our medical meetings that suddenly you may find say MCA's degree on the right nasal cavity, or doctors who are specialized only in the nasal cavity or something like that, which is going to come in the future, and this is happening slowly. So are we going to work in these silos in the future also? I remember my father was a general practitioner, and I remember even my uncles and all who were practitioners in small towns as MBBS doctors. They used to do surgeries, they used to do cesareans because they were not available at that time. Over the years, things have changed, and now more and more specialization is come into play. But is it really that we are going to work in these silos in the future also, or is there something else that is there that we can think about to bring, as it is brought in the Western countries, in some of these countries also, to help the patients and the doctors in general in the future also? So, as Mr. Mangal has already said, there is a vast difference between credentialing and privileging also. So basically what the councils today are doing is giving you credentials. That means after you have passed your degrees or diplomas, you submit to the council all these details, what you have done. And after going through that, the council decides to give you the license to practice as a doctor and as a specialist in that particular faculty or not. And this is done by the state medical councils at present. Whereas privileging is something where not beyond your degrees and your diplomas, we take into consideration that you have got the experience and the competence in that particular area or in that particular specialty. Because of your past experience, you have got the know-how of how to treat these patients. So can we really go beyond credentials as far as the council is concerned? And this is, I think, what the main topic is today of this esteemed group to discuss and to come to some conclusion at the end of that discussion. So let us see what are the rules and regulations at present which govern as far as this aspect is concerned. As you know, the MCI Code of Ethics 2002 is still into force. And what does it say? The section 1.4.2 basically says that the suffix that you put after your name should be only recognized medical degrees or such certificates and diplomas and memberships honors which confer professional knowledge or recognizes any exemplary qualification and achievement. So even if you see in the Code of Ethics, it is written that you can go beyond just the recognized degrees which are there by the given by the MCA. And what does section 7.20 say? That a physician shall not claim to be a specialist unless he has special qualification in that branch. So it does not talk about special degree or special diploma or in that branch, but it talks about you have a special qualification. And as we are aware, there are qualifications which are also given by reputed universities, reputed institutes, which may not find their name in the schedule of the MCA or the NMC. Now the NMC has come out with the new Code of Ethics 2023, which of course at present is kept in abeyance, though it was put in the public domain. Now it is very specific and it goes beyond what was there in the MCA Code of Ethics, where it says that RMP shall not claim to be a clinical specialist unless he or she has an NMC recognized training and qualification in that specific branch of modern medicine. And this is where the whole issue of the discussion starts. Of, are we going to stick to this, or are we going to go beyond this also in getting some rules and regulations as far as the councils are concerned? So let us see, I'll just go fast through these slides. But there was an RTI application which was done by Mr. Amit Karkhanes, and he asked these questions to the MCI. And they said that, can a gynecologist perform sonography and endoscopic surgery? And it said the answer given was yes, if it is related to gynecologists, they can do that. Though he is not a specialist radiologist, he can do a sonology, which is restricted to the gynec, because that is what he has been taught during his MD classes, He has been taught sonography of the pelvis, sonography of the, as far as the gynec and obstetrics is concerned. Not only that, the second question was, what is the difference in the scope of work between the MD general medicine and a DM cardiology? Because that is a big issue which is coming up. A lot of cases have come up in front of the councils also of can an MD really do, can practice cardiology. And there they have spared as far as the MCI code of ethics, that means which is still followed as of today. No specific information is available in the council's regulations. So they are also not, the council is also not sure if you can do it, if you can't do it, because nothing is put down. And as you know, legally, it has to be there in some rules and regulations or some act for you to follow that. So what does this mean? That as of today, an MD medicine can practice cardiology if he has a qualification in cardiology, even though which is not recognized by that MCI. Of course, this may change once the new code of ethics of NMC comes into play. And then also, the law does not prevent an MD medicine having a qualification like that conferred by, say, in Maharashtra, we have what is the College of Physician Surgeons, which is not in the schedule of the MCI, or some of those diplomas are not there or in the NMC at present. But yet in the state of Maharashtra, they are allowed to practice as consultants because they have got training through this College of Physicians and Surgeons. So, there is a dichotomy between what is being practiced and what is being said on paper as far as this aspect of privileging is concerned. And of course, the Supreme Court, what it has said is that a doctor is negligent if he does not possess requisite skills, which he professed to have possessed. Now, even the Supreme Court talks about the skills, the training. It does not talk about the degree or the diploma or the certificate that you have received, which is recognized by the MCI or by the NMC. Another RTA application which was done, which asked, can an MBBS perform cesarean surgery, hysterectomy, and other surgical procedures, which as of today, I think some of the judgments given by the courts say that he cannot do that. But the clarification given by the MCI in 2014, and I'm talking about 2014 when already the Code of Ethics 2002 was in play. What do they say? That the special qualification means degree, diploma in the concerned specialty. However, this provision does not debar a doctor having proper, documented, certified, adequate training exposure in an institution recognized by the MCI, thereby gaining competency and experience to work in that particular field or that particular branch. That means today, the council gives what is called as the additional qualification once you do your MD, MS, MCH, DNB or whatever. So those are given to only those, degrees and diplomas which are mentioned in the schedule. But the MCI itself also has said that it can go beyond the schedule if you have done that particular certification course or that particular training from a recognized institution. Beyond that also, let me tell you, even the government itself does not follow these guidelines which are there as far as MCI is concerned. Today, we find in many of the government institutions, they say that Ayush stream those who have done the Ayush stream, non-MBBS people can practice modern medicine to the extent of their training. So if we talk about that extent of their training, let me be very clear that even people like MD, medicine, are also trained in cardiology. MS surgery are also trained in urology, pediatric surgery, etc. But on one side, we tell them that you cannot practice this stream. But on the other side, the government says that the Ayush people can practice to the extent of their training which they have got during their learning days. So it has also equated a nephrologist with an MD medicine having 1 year training in dialysis. So the government also has understood that it is not easy to find nephrologists to run all the dialysis centers everywhere, and they have allowed these MD people. Routinely, MBBS graduates perform even in the medical colleges. They perform post-mortem, which is best done by an MD in FMT. So that is a specialization which is there, but even the MBBS people are allowed. And of course, the greatest aspect is that under the PNDT Act, a person without a qualification in radiology, that means an MBBS person who takes a 6 months training in ultrasound will be allowed to practice ultrasound under the PNDT Act. So if these changes can be brought in by the government, is it time for even the National Medical Commission to, discuss if they can go beyond what is written down in this act? And let me tell you that, as far as the Maharashtra Medical Council is concerned, we have deliberated on this issue, and those people who are those doctors who have done training and have been practicing that particular aspect or super specialization of medicine, we have given them special certificates saying that yes, they can do this type of surgeries or this type of procedures, and this certification has been given officially by the Maharashtra Medical Councils. Let me just give you an example. When any new course comes, like for instance, suppose MCH colorectal comes into play, what does the MCI or the NMC at present say? That those who have got MS degree and have got specialized training in colorectal surgery can become teachers, can become examiners for up to 10 years, till the MCH colorectal people come out. Now, what do you say? You say that I can teach students, I can take the examination and say pass or fail as far as MCH colorectal is concerned, but after 10 years, I am debarred from doing colorectal surgery. So I don't think that is even fair. That is does not give a level playing ground even for this. So that I think it is high time, and we have got all legal luminaries also over here. It is high time, definitely, that we have some white paper on this, and we wake the National Medical Commission, discuss this with all the stakeholders, and come up with some, definitive rules, regulations as far as this privileging is concerned, so that the medical practitioners, not only the medical practitioners, but even the patients, especially in the small towns and rural areas, can definitely gain from this practical training that a senior doctor has received in that particular subject. So thank you very much, Mr. Mangal, for allowing me to put my views. They may be a little radical views in today's context, but I think they are the views. I think this is something which should be discussed. Maybe I'm right, maybe I'm wrong. All the other legal luminaries and senior doctors will tell that. So thank you very much for having me over here and letting me discuss this point. Thank you.
Thank you, Dr. Uttare, for that wonderful talk and that presentation. I now invite our moderator for the session, Dr. Parag Rendani, to take over the proceedings. A brief introduction about Dr. Parag Rendani. First, he is a very dear friend, and then he is the CEO of the Vocard Group of Hospitals. He is also the principal assessor and part of the program on implementation training, accreditation, and assessor training for NABH. Over to you, Dr. Rendani.
A very good morning, and thank you very much, Ravindra, for that small introduction. I think it's extremely relevant to have this conversation in today's day and age. I have three important things I'd like to say before I actually start moderating. I think first and foremost, we must understand and accept that while today we discuss the privileging related to doctors, within the medical cadre, there are multiple other privileges that are required. We are talking about privileging of nursing, who should actually administer a chemo medication, who should actually be doing certain colostomy care, etc. The other important thing is that we must remember that this is a movement which is evolving. And therefore, a professor of neurology at a hospital 10 years ago used to be what used to be called an MD in neurology, because they might not have been a DM then. And I'm in total concurrence with Dr. Utturesa. I think it's extremely relevant to note that as the medical powers that be keep looking at evolving higher and higher degrees, we must not forget that there are people who have given their careers, their lives to achieving that MD degree or that MS degree. And therefore, to essentially rule out that they are not allowed certain practice is incorrect. And I think the third and most important aspect, which to my mind is relevant today, and which I'd like to keep a general note of awareness for all our esteemed policymakers, doctors, hospital administrators, my accreditation colleagues, as well as, of course, the patient voice. Please do not forget the voice of the patient in terms of patient safety. Please do not forget that we have got an India where we are happy to discuss that we've got MCHS to deal with our cardiac surgeries. But remember that there is also Bharat. There is a big Bharat sitting out there where we don't have those privileges, because essentially at the end of the day, it costs an X amount of rupees to buy out your rural practice and, pay the government and say, I don't want to go to a rural area. I'd rather sit in Mumbai or Delhi and go ahead and complete my practice. We must not also forget that while there are huge vested interests, there are financial equations and so on and so forth. Our job today is to focus on policy. Our job today is to understand what would be the recommendations that we would like to make to to our honorable policymakers in Parliament as to how they should be allowing us to extend privileges to people who are trained in the science of medicine. Today's hospitals, most hospitals, thanks to the National Accreditation Board for Hospitals and Healthcare Providers, have already started a certain amount of granting of privileges based on what they see are the credentials. Credentials, ladies and gentlemen, essentially refer to four major areas. We are talking about education. We're talking about licensure or registration with the respective medical council. We're talking about experience, and we're talking about specialized training. These are the four areas of credentials that we would normally look at before we grant certain privileges. Remember that the presence of credentials in any science, does not mandate or guarantee the presence of competence. And therefore, it's extremely relevant to try and build in a measure of competence assessment, which we do at all our accredited hospitals in this country, with be it doctors, be it nurses, be it technologists. It's extremely important to evaluate competence. But I am not the speaker today. I am the moderator. And with this small hint of a little bit of information that I felt was relevant to our conversation today, I'd like to invite the esteemed panelists of the day. It's a beautiful Sunday morning, and I know that all of you are just bursting with energy to contribute to today's conversations. And without further ado, I'd like to invite our extremely senior and a panelist with whom we've had the privilege of interacting in earlier conventions, Dr. Gurbeer Singh, a professor emeritus at Chitkara University with over 50 years of experience in healthcare. Earlier, a salute to you, sir, has been with the Indian Air Force, later has worked with Fortis Healthcare, has been part of the world standards bringing into India. Dr. Gurbeer Singh, over to you. Your views on how we can accomplish setting up privileges. What are the challenges from a medical standpoint in terms of contributing to policy?
Thank you very much, Brad. And I am so pleased to say that you have laid out such a wonderful track for all of us to get the road running now. The first and foremost, our first speaker very rightly had pointed out.
I'm sorry to interrupt, Dr. Singh. Dr. Gurbeer Singh, I think there is some connectivity issue. We are not able to hear you clearly. Can I request you to log out and log in again? Meanwhile, we'll continue with some other speaker and we'll ask you to come back again. Just if you could log out and log in, probably it will
Our
go
apologies, sir. Our apologies. I was really looking forward to listening to you. Well, while we wait for Dr. Singh to get back to us, may I invite Professor Dr. Hemant Dusia, sir. He is the former Dean Academics and Professor Emeritus of Dentistry at the Lokmanya Tilak Medical College, Mumbai, and Chairman of the Board of Research for Medicine, Physical Therapy, and Occupational Therapy at the Lokmanya Tilak Medical College. Dr. Dusia, you have been an academician. You have driven a college, one of the leading colleges. I must compliment you in terms of policy, in terms of implementation of graduate, postgraduate programs. Do you see the differences in terms of your students, as they evolve? How do you think we can actually contribute to privileges, Dr. Dusia? Over to you, sir. Dr. Hemant, sir, you're not audible. Yeah, I'd like you to kind of, sir, we can't hear. Thank you, sir. Sir, you have about 3 minutes to contribute, sir. Dr. Dusia.
No, he has to unmute himself, Parag.
He has unmuted, but he's muted himself again, sir.
Yeah, yeah.
Yeah,
Good morning,
we can hear
everybody.
you now.
Am I
Thank you, sir.
audible?
Yes, sir.
Honorable Convener, sir, Dr. Uttare, Dr. Rindani. I'll tell you, I will finish within my time. Dr. Uttare, sir, your CV reminded, see, I was working, I'm a professor of dentistry. I've done my maxillofacial surgery. So why I'm here, when I stop speaking, when I saw St. George JC, I was trained in surgery under Dr. Nagarkatti sir, Dr. Chhatriwala, Dr. Acharya sir. And we had Dr. Sani. So that time we had, because all our medical colleagues would, keep all the problems under the wraps and they would take the responsibility. Today it's not the thing. Now, I will come to a conclusion as to why I'm talking here. How the Dental Council and NMC today is related, how the two councils relate, and finally, also if there's a dispute, all the cases, maybe NMC or DCIV is going to go to the honorable judges sitting here. So I'm so very happy, Dr. Ravindra Ji, Dr. Advocate Vajpayee Saab, for inviting me here, and it's a huge platform. A lot of honorable judges, people from NGO, lawyers, doctors, public. So, I will take you back, and of course, very, very famous case, Ashwin Patel versus Poonam Verma. No, very simple. He was a homeopath. Somebody went, this lady's husband went, he gave something, he died. But, and of course, the Honorable Justice Kuldeep Singh and Justice J.S. Salki, I'm sorry, Sabhir Sahib, they ruled that he is a homeopath, and despite his training under a medical doctor of medicine, he was at fault. Now, this is one case. I'll take you back to dentistry. The earliest recorded case, which was not actually heard by the honorable court, was one Dr. Naveen Ram. To him, a patient called Abhiram went for a earache. Now you'll be wondering why a earache patient should go to it. This is again a matter of debate, because there are conditions, something like TM joint pain, where the ear is also referred to, the pain is referred to the ear. Now this fellow, Dr. Abhiram, Naveen Ram, gave him some medicine, the patient died. Now, even before the case went to the court of law, the local superintendent of police took cognizance, and somehow he was asked to not practice. So this is one extent. Now we come to the present. A lot of cases. The medical state, Master Dental Council is today flooded with cases against doctors, dentists. And the whole thing revolves around whether he was supposed to do or not. Implants, number one. Lots of implant failures, lot of root canal failures. And, the very, very burning issue between the NMC doctors and dentistry is whether an oral surgeon or maxillofacial surgeon can perform procedures of aesthetics, hair transplant. I'll come to it in a moment. So we go back to implants. Now, what is happening is a dental graduate who has just passed maybe 2 years before back also puts in on his board as an implantologist, which is totally wrong. The Dental Council today has allowed 3 specialties: maxillofacial surgery, periodontology, and prosthodontics, to do these things. Now, it becomes very difficult for the state. I was also the state president, state dental council, to decide as to who is at fault, number one. So this is one important thing, because there is a gray area now. Because as per the Dental Council Act 2014, 10J10(2), the council says a BDS can perform all the procedures that an MDS can perform. So, similar to what earlier the MCI meant before the NMC came up with the revised regulation. So now there's gray area. He is supposed to do, he is not supposed to do. So, what? This is one case. Also now coming to the broader part is, huge human crime. Very famous case, of, people going to, actually what happens, I'm a maxillofacial surgeon. When I was practicing, we would stick only to the oral area, maximum maybe jaw fractures. Zyada se zyada gaya to, for example, in JJ, we had a joint maxillofacial tumor group. We had one Dr. Pillu Hakim, Dr. Vijay Chaudhary, and all, and Dr. Dawar. But there was training, there was interaction, and always, for example, if we did oral oncology, we also had the, I'm talking about San Hospital. When I was operating, there was either Dr. Professor Thatya or Dr. Mukund, so it was beautiful. And if something went wrong, they were the ones who would take the onus to save us. So this is now what's happening today is oral surgeons, they have started left and right and center, with pallets, oncology surgery, or head transplant. So what is happening now is, people are little this thing, which I can fully understand, because as Dr. Utturi said, there should also be a moral component to that. So then there was a complaint to the council, very famous Dr. Rajesh Buddhadev, he was the IDA VDL president. So he wrote to the dental council. They said you go to the Kerala State Dental Council, and there's also a letter written by the Rajiv Gandhi Institute to Dental Council as to define whether these people can do or not. Finally, now I'm just finishing. The Dental Council has come out with a gazette that oral surgeons can perform procedures like dermabrasions, removal of tags, lasers, and hair transplants. Even today, the Maharashtra state has come out with a gazette. So now I'll sum up. So what's happening now is, amongst dentistry, endodontist or a dentist should do root canal, implantologist, perio, prosthetics, or an oral surgeon should do an implant. And finally, so now we have conflict between the dentists ourselves through council. So, why I've talked about this, we have lots of learned judges. One fine day, this has, and of course, but I was all, my life was in the medical college. And what I worked, as I said, Dr. Sani, all my life, Dr. Thatya, and also sir, before I ram up, Uttara sir, I was the chairman of the Trinity Conference, and always we would forget to get this thing, accreditation, and we would go to Supe sir, and he would full Karuntak, and next moment it was. So thank you once again. So that I was always trained, and I was born, brought up there. So that was my view, but privileging in dentistry also vis-a-vis its overlap between the medicine is a burning question which needs to be answered. So thank you once again, and thank you, Raviji, Advocate Bajpai, for having me here. Thank you very much.
Thank you very much, Dr. Dusia. I think that was some worthy contribution, as well as a trip down memory lane also. Thank you very much for that. I'd just like to check back with Dr. Gurbir Singh, because this is a person, if Dr. Gurbir Singh is back and available. So I'll just frame my question. You've been part of one of the two larger hospital chains, which is the Fortis Group. I mean, your own views, personal views, as well as an organization, how do you actually look at granting privileges to people? Would you, for example, give a MD medicine cardiology privileges, interventional cardiology privileges? How do you actually structure this entire thing? Over to you, sir.
Okay, so
I think we should request Dr. Gurbir Singh to shut his video, then we'll be able to hear him, because it is still breaking, voice is breaking.
Yeah, right, Dr. Utturi. Thank you, sir.
now is it good?
Much better, sir. Much better.
Oh, okay, so I can have my own song and dance now.
Yes, sir.
All right.
Yes.
All right, so your question is very pertinent, because when we were in the services, we had our own standards, which were already gauged and given to us. But once I moved over to the private sector and the Fortis Healthcare, as you were mentioning it, the first speaker had also mentioned something about criteria for determining privileges. Now, when we say criteria for determining privileges are given to individuals. So we must consider 4 or 5 factors here. One is individual character, individual competence, individual training, individual experience, and individual judgment. Now, when I say coming back to what Parag had just mentioned, whether we can grant a certain privilege to somebody. Now, if you take the this is also the extra of the earlier speakers, unless there is adequate experience in that from a recognized institute. Now, I am a pathologist, but I speak for, say, a surgical oncologist. In his 5th year, that is his final year of his residency, it is purely devoted to his own core subject, wherein those 12 months, 120 odd surgeries have to be done. And also, now again, person doing intervention, is he competent enough to be handling something like critical care? Now, these boys who do their residency in surgical oncology have to have knowledge of at least 7 disciplines, which include non-traumatic hemorrhage, intubation, those placements of those to deliver the chemotherapeutic drugs, etc. They must also have the allied knowledge of the fields with which whom they are going to interact. Okay, and the other thing is, just by granting privileges, now there is a variance in practice environment with which we are seeing, it is going beyond hospitals. So I must again reiterate that privileges should be granted, always should be site specific, so that the individual are only requesting privileges to provide services that are offered at the particular site. They might have the competence, but they cannot be given a privilege which is for a task which is not being practiced in that place. The other thing which was mentioned was also about few other privileges which are to be given to an individual. Those come under the charter of non-core privileges. Like once you become an oncosurgeon, the use of a laser, breast cryoablation, administration of sedations and analgesics, these also become a part of your practice. But yet, like what we would do is that every year, even the endoscopists, doctors who are doing the gastroenterology, would associate with the head of department of anesthesia, to be conversant again on across the table, because they have also used in their life sedation and analgesia, but the reprivileging that, yes, they are current in their practice. And privileges for anything should not be extended for more than 2 years. Parag, I hope I have made myself clear on certain aspects. Yes,
Absolutely.
one contentious issue is there, that when we get very senior professor level people into the private practice, I know all of us shy away from a certain degree of our a duty, whereas to call a spade, we must always ensure that the physical fitness of an individual has been ascertained, and so that there is physical and cognitive ability to safely perform their duty. Someone may have been doing thyroids 20 years back, but if he has not done thyroids in the last 1 year or maybe 2 years, if there's no no logbook to support that, he should not really be allowed to do a thyroid. So that is how we would rationalize, be logical, and be fair to a person like so poignantly had been brought out, that we spend our life in the medical services learning, yearning, and then doing work. yes, equitable distribution of work and a playing area which is level field should be provided. Thank you very much.
Thank you very much, Dr. Singh. I think that was to the point. Let me remind once again all our participants that essentially what we're trying to do here is try and ascertain what are the clinical privileges one should be able to grant based on the qualifications, because that's currently the letter of the law, which is trying to ascertain how we can put in place a set amount of privileges legally so that we are able to ably guided by the policymakers, and when it comes up in court, how do our honorable justices deal with it? I now have the pleasure of introducing Dr. Anil Kumar Chilimunta. He is the Executive Vice President, Professor and Head of Management Department at the Meetas of Seventh-day Adventist Group of Hospitals and Colleges in Surat, Gujarat, Jowai, Meghalaya, Ranchi, Jharkhand, and Newswood in Andhra Pradesh. He's also the Chief Operating Officer of AWR 360 Health USA. Anil also is an old friend. Anil, quickly, my question to you is, and you can contribute further also in about 3 minutes. You are running hospitals which are actually located in Bharat. Okay. While we here at the corporate hospitals, at the hospitals which are internationally accredited, etc., may demand that you need to have this qualification, you need to have that qualification. What is the ground reality? Bharat mein kya ho raha hai? Do you get an MCH cardiac surgeon to come and operate? Do you get an MCH urologist to come and operate? And how do you deal with these challenges of granting privileges to what is called the lower level, quote unquote, of medical qualification vis-a-vis what is generally accepted by the National Medical Commission? Over to Anil.
Thank you, Dr. Parag Vindani, and honorable judges and all eminent personalities on the panel here. I manage a hospital in a city, and also I manage a hospital in the rural area. Now, I think when we talk about privileging, we need to look at the very aspect of where the hospital is situated actually, because is our country really ready for privileging? That's question number one. Why do I say that? Because are we having the patient and doctor population ratio which is equivalent to an advanced country which is following privileging? Today, if you're looking at what some of our doctors have spoken in a few minutes back, we're looking at doctors who are to be well trained and educated at regular intervals to update themselves. But today, if you look at the rural area, we have a simple, our main spinal cord of our healthcare, the primary health centers. That is one place where we lack doctors significantly. And I think even a nurse does a simple delivery because there's a lack of doctor. And even if we, and here we at the other end of the whole bargain, we're talking about privileging of doctors. So there is a dichotomy, Dr. Parag. What I understand here is there is a dichotomy, and especially law should actually look at the perspective of whether it is a corporate hospital or a hospital in a city which has got good availability of doctors, or is this privileging available for a person who is in a village or in a small town where they're practicing. For example, I manage a hospital at Newswood, which is a town. It is a 100-year-old hospital, served that place so well all these years, but it's very difficult to get doctors. First thing, to get even the RMOs is the biggest challenge. And to cater to the patients, that's going to become a challenge. Now, if you look at a patient population ratio with doctors, we find we are slightly below 1. And it comes to an advanced country, they are having six doctors for 1,000 patients or 1,000 population. But whereas India, we are at 0.89 as of 2021. So by we doing privileging, are we dragging our ratio still lower to 0.89? A question for all of us as we start discussing and contemplating about privileging and credentialing. Thank you, Dr. Parag.
Thank you very much, Anil. I think that was very crisp and brought out again the point that I spoke about earlier, India versus Bharat. What exactly do we want to do? But to that point, I'd just like to add, As we know, we have the Honorable Prime Minister a few years back launched what is called the Pradhan Mantri Jan Arogya Yojana, what is today being called the Akhil Bharatiya, extended to the Akhil Bharatiya Digital Mission. We are all looking at getting unique health identifiers under the Akhil Bharatiya Digital Mission. Under the PMJAY, let me just bring to the knowledge of the honorable panelists that in whatever city you are, in whatever village you are not allowed to use that 5 lakh rupees for our patients, let's say for oncosurgery, unless you are a qualified oncosurgeon, which means that irrespective of where our Indian, quote unquote, or Bharatvasi is getting operated, he cannot get operated unless the necessary credentials are made available. And therefore, that surgeon has to be on record saying, I am a trained and qualified licensed oncosurgeon. Let's not talk about experience right now. We are not talking about competencies. We are merely talking about grant of privileges. But the PMJY does not allow even a maxillofacial surgeon to operate on head and neck oncology. So that's the condition we are currently in. A question of whether we are being properly guided at that particular high national level, something that we might want to introspect again and look into. These are problems that Indians are facing, and therefore they have to travel huge distances to go and get oncosurgery done, travel again for follow-up, a drain to the exchequer, a drain to all providers, and that's something which we must definitely contemplate as we go along. As we go along, I now move to a very good friend, Dr. Suvin Shetty, a pathologist by training, by licensure, practicing pathology. He is also vice chair of the Quality Health Professionals and member of the governing council for an extremely important organization. I also will have the privilege to speak to Dr. Vijay Agarwal, president of this organization, which is a consortium of accredited healthcare organizations. Suvin is also the joint secretary Maharashtra chapter of the Association of National Board of Accredited Hospitals. The reason I mention this to our honorable policymakers is that these are the organizations which are currently trying to infuse quality along with our National Accreditation Board for Healthcare Providers, hospitals and healthcare providers. And these are the people who are working with whoever wants to work to try and establish a certain modicum of quality, a certain non-quackery, if I may say so, in the system. So these are our silent workers. Dr. Suvin Shetty, as a quality professional, as a pathologist, in your own area, you've got the CMLT run labs, the DMLT run labs. You've got biochemistry not being allowed to do hematology, though they are all MD pathologists. How do you look at this? You also work in a reputed hospital in Mumbai, the Hiranandani Hospital. How do you handle these challenges? Over to you, Suvin.
Yeah, these challenges we do face. I mean, we face challenges at 2 levels. One would be at what you said, at CMLT, or probably which are considered to be sort of illegal labs in that point of view, because they are not managed by doctors themselves. So that is one level of issues that labs are facing. And another level is about credentialing at sections, whether biochemistry, micro, sero, hematology, and those levels. So, the former would be more of a legality, I should say, because that is clearly within the purview of MCI or NMCA Act, that these are centers which are not being managed by doctors themselves or not supervised by the doctors themselves. So I leave that to legally, and there are literally a lot of legal cases which are there, which have the cases in the judiciary which have clearly mentioned what rule of law is all about. With respect to the other, that is where the credentialing and privileging would come and play, because this is the area where the expertise or the domain expert of the individuals who are practicing, say, biochemistry, say, hematology, say, hematopath, say, microbiology, or say, clinical path would come in play. Traditionally, these were all done under the domain of, say, a pathologist a couple of decades back. Now, with advent of division in this area, there are now individuals or professionals who are come up in the system where we can offer them the job in this particular area. but it's still early days. We still don't get enough of these specialties in the city, in the metropolitan city. So beyond that, I mean, it would be very far-fetched to say, okay, we can go and try and categorize them into various categories in the field of laboratory medicine. But yeah, going forward, we may see a lot of divisions in this particular area. That is where we are. In fact, we faced these such questions during the point of accreditation process, whether we can involve more of such specialties as such, sir.
Thank you, Subin. I really appreciate that answer for the sole reason that you have been working incessantly to promote non-quackery safe cultures within the organization. My next question is going to be to one of the torchbearers of patient safety, one of the persons who is currently driving patient safety, not only in India, but across the Asian subcontinent, Dr. Vijay Agarwal, my own guru on a personal note, president of the Consortium of Accredited Healthcare Organizations. He's played a key role in driving national programs such as the Pulse Polio program. He was also the founder chairman of the Nursing Home Forum of Delhi Medical Association, responsible for working and setting up Max Hospital in Saket and then Pushpanjali Crossway Hospital, which is now Max Vaishali. Dr. Agarwal, sir, welcome to this conference, to this meeting. And while you would be, you have your own views, which I'd welcome you to kindly present, but I have a very pertinent question specific to you. You are one of the, along with the chairman of the Quality Council of India, along with the Secretary General, the CEO of NABH. I think that I would definitely say that you're privileged to be one of the torchbearers, the flag holders of the patient safety movement in India. At the end of the day, we all understand that the granting of privileges is essentially meant to filter out, to weed out people who cannot deliver quality patient care, not only as per law, but also as per competence. And therefore, essentially, everything is focusing on patient safety. I'll just go back for a minute to what Anil presented about having differential privileges to the citizen of Bharat versus the citizen of India. And I think it's extremely relevant to understand that this demand-supply gap in the so-called super specialists versus the privileged ones. How do you think we can meet it, sir? Over to you, sir.
So thank you, Parag, for this very elaborate introduction. Thank you. And first of all, I agree with a lot of points raised started from Dr. Utre to you and to Anil. So in everybody, whatever points they have raised are all in a way pertinent. My issue is number one, that privileging, and I like what actually Dr. Gurbir Singh also pointed out, number one should be institution specific. So it's not an issue of somebody giving me the privileging right. Privileges are given by an institution. And therefore, if we accept that as a concept, then probably in a tier 2, tier 3 town, and an institution can give privileges depending upon the availability of the people and all that. So you should be empowering these institutions to give privileges according to the situations which are present over there. We cannot look at the credentialing is being given by the bodies like the NMC or the institutions, while the privileges can be given. And there are many factors. I think Dr. Gurbir Singh very nicely pointed out. Very pertinent question Anil raised, are we ready for privileging? And the issue is this, that it is like somebody trying to focus on the tie and the bow when I'm not even ready with my undergarments. The issue is this, that in this country, we do not have as yet data available to a common man about all the doctors and the providers present in a very clear-cut, crisp way. We do not, I want to know within my 10 kilometers who is a neurologist, a cardiologist, a physician, or somebody. We do not have this data. In spite of all the medical councils, they don't talk to each other. So there is an effort by the National Medical Commission, National Health Authority. They are not trying to do all that. But I think we need as a country, first of all, to focus on this basic issue of very clear-cut enumeration of the doctors and the providers. It can include the Ayushmans also. And that is when you can start building the ecosystem of people trying to know as to who is available to treat me and for what. The problem is that the availability of the super specialists, which is a good thing in a way, but they became the people who were now trying to fight out the other people, like the, let's say, I am aware about, even in a reputed institution, for example, the plastic surgery department was being headed at Max by someone who was not a qualified plastic surgeon. And he was an excellent plastic surgeon. It was doing excellent plastic surgery, but that was being fought by the people who were qualified. So a lot of this issue of privileging is being fought by the people who have been trained, and now they want some kind of an exclusivity that only they should be allowed to do work in that area. A time may come for that, but I don't think that we are ready for that as yet. And not at all, if you look at Bharat, or I will say not even in India, the issue is this, that every institution is going to face a problem. How do I provide services to my patients? And non-availability of the so-called, and second thing is, I want to understand, how can anybody be privileged without being not privileged earlier? How did he come to the stage of being privileged? There had to be, you were not born privileged. You were not born that you just passed your MD or whatever, even you did DM, and then somebody gave you that privilege. So there is no doubt going to be a time in which a person is getting trained. And during that period, how are you defining that period? Who is privileging? Second, another point I would like to say, we are very poor in even our documentation of training. So even in terms of the logbooks and things like that, where are the logbooks? A person who comes out of even an MBBS, we do not have very clear-cut data that, all right, he did 3 liver biopsies, or he did a pleural tap, or he did what, or he did what. So I think we need to somehow, first of all, strengthen the basic systems in place, then on to move on to privileging, and that also should be institution specific for a particular period. It's definitely a very interesting topic, has been made more interesting by the court pronouncements in various times, and we're giving a different viewpoints. So thank you, Parag. I don't know.
Thank you very much, sir. I think that was extremely productive, because we have a very clear contribution to our white paper, which means that there needs to be a system and process for a national repository of who has done what procedures during their training. And probably this is something that we need to work on. I salute that. A quick yes, no kind of a question to all my doctors, my doctor colleagues, as I wind up. While we understand that we may not be ready for quote unquote detailed privileges being given down by the law and through statutory bodies like NMC, yes, no, do you think we are ready for at least broad guidelines to be given by National Medical Council? Quickly, sir. Dr. Singh, we'll start with you. A yes, no would suffice, sir?
Yes.
Absolutely. Dr. Dhusia, sir? Okay, I think Dr. Hemant is busy. Dr. Anil?
Yes, sir. Yes, sir.
Okay. Suvin, what is your view?
Yeah, broad guidelines. Yeah, I think it's a must.
Yeah. Dr. Agarwal, sir?
Yes, based on what we have discussed. Yes.
Absolutely. So I think that's extremely interesting. Now I move on to my extremely eager beaver colleagues, my lawyer friends. I have 2 extremely senior professionals with me. I've had the privilege of working with them before. At the very outset, let me thank them for being here and invite Advocate Mayank Shirsagar, who is an advocate on record in the Supreme Court, a strong focus on cases of medical legal, areas, specifically medical negligence. Advocate Shirsagar, over to you, sir. Your views on why and how do you think privileges should be granted? Do you think there's a necessity? What is the law on this? And how do you think your views would help to carve out more clarity on this? Over to you, sir. Mayank, sir?
I think sir has to unmute.
I don't even know what they say. Advocate Mayank Shirsagar, sir? Okay, we'll come back. In the meantime, I request Ravindra ji with the team to reach out to Advocate Shirsagar. Advocate Bajpai ji, are you there?
Yeah, they are both seen over here, but I think their videos are off.
Okay.
Video and audio both are off.
Yeah.
Is there some sort of a satyagraha which we don't know about, Ravindra ji?
Sir, just give me a moment. Bajpai ji will join us in a second.
Yeah, okay.
Yeah, I think he's seen now.
Yeah, okay. Advocate Bajpai. So Advocate Bajpai is an advocate at the Supreme Court and also the Honorable Director of the Institute of Medicine and Law. Advocate Mahendra Kumar Bajpai ji, over to you. Your views on this, the need for this, and please.
Thank you, Parag. Along with me, all the legal friends present here would be very happy. There is nothing like privileging in law in legal profession in India. Any lawyer can practice anything. Whether you were in the chamber of a civil side practitioner or a criminal side, once a client walks in, you are entitled to accept the brief. I feel very happy, Parag. Let me share these emotions with you and this August gathering. Parag, with the learned judges here, we lawyers would want to keep quiet. At least I would do that. But again, there are few things. One, you all know I have been working with doctors and hospitals for a pretty long time. And I was always wondering, why is it that the gynecologists are fighting with anesthesiologists? Why is it that gynecologists are fighting with radiologists? Thanks to Dr. Vijay Agarwal, sir, I got, probably I got the answer. Some type of exclusivity is what every specialty is looking in for. Friends, the question is, there should be some guideline, or rather the answer is there should be some guidelines, broad ones or not broad ones. But the guideline should be there. At least the doctor fraternity thinks so, and I'll be very eager to hear from the learned judges who are here. But let us not forget one thing. There are certain specialities which have just sprung up. Cosmetologist. Every doctor is today a cosmetologist. A dentist, a simple MBBS, and you name it. Are we going to call them qualified, or are we going to call them quacks? Privileges are certainly required. We already have a judgment from the courts who are facing medical negligence cases day in, day out. The doctors are showing their degrees. They are showing we have done residency, so we have the requisite skills and qualifications to do this. The hands of the courts are tied. And until and unless some broad guidelines come, it would be very hard to deliver justice. My last comment would be the Honorable Supreme Court of India in the case of Samira Kohli has very aptly put down that let us not ape the West, especially the American system. The system that we need to follow has to be India specific. Thank you, Parag. Thank you for giving me an opportunity to speak.
Thank you very much, Advocate Bajpai. I think that's extremely relevant, and maybe on a lighter note, maybe at some stage we might need to look into privileging of lawyers and see how we can look into that, sir. That's extremely just as in jest to lighten this complex discussion.
Can I add something? Ultimately,
Of
that
course, sir.
will go to courts only, you know.
No, they're extremely important. Advocate Mayank Sagar,
Good morning.
advocate at the Supreme Court on record, dealing with a fair amount of medical negligence cases. While I look at listening to you actively, I'd also like to understand amongst the cases that you deal with, Advocate Sagar, how exactly, what do you see? Do you see this as an issue, first of all, in terms of non-privileged people, inappropriately credentialed people dealing with cases which they're not supposed to? I'm not even talking about quacks. I'm talking about an MBBS doing something that a cardiologist should do or something like that, a higher level of care. Over to you, Advocate.
Yeah, thank you for the opportunity, sir. First of all, I would like to clarify here that some of the judgments that I have gone through on the aspect of privileging, I find there is a stark difference between the area where the case has happened. For instance, if it is a rural area and there was a non-availability of a particular specialty, and for instance, a surgeon doing a delivery, it was not seen as something against the code or something against which will be penalized. And the surgeon in such a case was not held to be negligent, even though he performed a surgery which was not of his own discipline. So I believe, as Mr. Bajpai rightly put it, that what Supreme Court observed in the case of Samira Kohli is, let us come back to India and not follow the West. Here, the ground realities are quite different. And even the courts at times, and especially the consumer forums which deal with the maximum number of litigation generating out of medical negligence, they deal with the situation on a different footing. Where if, for instance, if it is a hospital like Fortis or a privileged or some super specialty hospital, where anesthetist or the entire team of specialists is present, and in those cases, if there is a negligence which has happened, in those cases, the hospitals are frowned upon very badly by the courts, and basically they are made to pay the compensation. But in the other cases, if there is a small town or a village or a small facility, or if it's in case of an emergency, the privileging is not strictly followed or expected to be followed. If we see a few judgments of the National Commission which has recently come in, or of the State Commission. So what I feel is, in India, privileging, yes, it has to be there. But I believe at present, the legal system and the societal system and the probably even the medical system that we already have in place, which is quite, it gets upgrading every day, is not in a position to have such a thing, especially in the rural area. So we probably, as rightly is looked upon by the courts, has to be seen in two different aspects, if I'm clear on that.
Absolutely clear, Advocate Sagar, which brings me to a very pertinent point, and I want to extend a conversation with you and probably ask Advocate Bajpai also to pitch in before we move to the patient advocates, which essentially means that, again, going back to Ayushman Bharat, you get paid the same amount of money whether you're located in a village in Jharsuguda or whether you're located in Mumbai. And essentially, the rules of the law, therefore, would apply differentially, irrespective of the amount of compensation given to you. irrespective of the services that you're supposed to provide under a uniform system across India and Bharat. Is that what I'm hearing, Advocate Shrisagar?
Yes, there will be a difference in application of these rules depending upon, because I may be corrected by, we have a lot of esteemed judges sitting here. It is also the existing surrounding circumstances which has to be looked into by a court while dealing with any case, and then apply the law or the letter of law on that aspect.
Fine.
And especially if it's a consumer litigation, because most of it, we presume that it will be consumer litigation. There will be a difference in application, as you have rightly pointed out. Number two, in India or in the Indian medical setup, there are credentializing should be enough for dehorse the privilege, if I am clear on that aspect. If
yes,
credentials are met, I believe anybody is entitled to do anything. This will apply in case of a smaller setup, rural areas, small cities, non-availability of specialists, because we cannot, and because there are other line of judgments of the Honorable NCDRC and the State Consumer Forums, which say that you cannot say no to a patient in case of an emergency. And what happens if something goes wrong at that moment? An anesthetist is not present. A surgeon does it on his own. So there will always be a difference. That is what my viewpoint on this is. I may be subject to, I may stand corrected by my learned judges and legal fraternity friends which are present here.
Advocate Bajpai, in your own language, any rebuttal on that? Sir, you're not audible.
How many minutes?
1 minute.
Seconds. Okay.
1 minute. I am supposed to moderate, sir, with your own dictum.
Where everyone knows who is moderating, who is running the show. So, Parag, we have Article 14 in Constitution of India, which talks about discrimination. Okay. There are two types of discrimination: positive discrimination and negative discrimination. Positive discrimination means the state cannot discriminate between two similarly situated people. But at the same time, the state has to discriminate between two dissimilar people, between two dissimilar individuals, organization, and situations. You have drawn a very good parallel. 5 lakh rupees in Bombay and 5 lakh rupees in a small town? No. So privileging also in the same breath. The privileging that would be required here would be very different from the privileging that would be required in a rural setup.
Thank you very much. I think it's brilliant. You've just given all the doctors on the group enough quote unquote masala to write to the Honorable Prime Minister to have dissimilar rates for dissimilar healthcare settings. I will quote you on that, Advocate Bajpai, and the Constitution.
PIL, 2 minutes, 2 seconds, PIL.
Anyway, it's always nice to have an interesting conversation, and I think we must not forget, and as I've said it probably 4 times in the last 1 hour, at the base of everything that we do, the predominant emotion driving anything and everything, including this discussion today, is patient safety, is patient well-being. And for that, I think it's extremely important to speak to a representative of the patient. I have the privilege of inviting and introducing Dr. Ratna Devi, who is CEO and co-founder of Dakshina Health and Education. It's leads a cross-disease patient alliance in India called the Indian Alliance of Patient Groups. Also the chair, ISPUR Patient Council, and immediate past chair of Board of International Alliance of Patient Organization. Board member of Healthy India Alliance, the National NCD Alliance in India, and the Asia Pacific Alliance of Rare Diseases Organization. I think that's quite a mouthful, Dr. Ratna Devi. Ma'am, from a patient's point of view, a patient walks into somebody who's got doctor written in front of his name and about 30-40 alphabets with a few dots and commas, some capital, some small written after his name. Patient को कैसे समझेगा privileges है नहीं है? Patient आज भी NABH के मायने भी नहीं समझता. your own views on why privileging is essential. Why do you think and how do you think it is going to help our patients get safer care, get more effective and quality care? Ma'am, over to you. You have 3 minutes.
Thank you. Thank you, Dr. Rindani. And a very, relevant point that you raised as to how do people know whether the person who is writing all those things in front of their name is actually qualified for whatever is written there, and whether those qualifications are from accredited institutions. It's sometimes people write 10 pages of accreditations in their signature itself. So you don't know how many of those are current and how many are not valid anymore. Having said that, medical science is based on trust, and usually the patient who walks into a clinic or who goes to meet a doctor, goes with the trust that they are going to get the best of care. So it's only when something adverse happens that the person loses that trust, and that is where the whole chain starts. So who educates the patient that, whatever has happened is not right? And let me give you a few examples. We work with patients with endometriosis and PCOS, and you know that both of these conditions are associated with infertility. So who decides, when the gynecologist is not qualified to do an IUI or an IVF, and when is the fertility specialist qualified to do that? It's only when there are multiple failures and the person then goes to maybe a IVF specialist, is the person told that, there is a new act in place and you were going to the wrong person and you spent lakhs of rupees with no effect. And that is where the distrust starts. So I think the whole issue of privileging first has to start with good communication with the doctors themselves. So it's the doctors who cut down the other doctors and tell them that person was not qualified, or this person did not have the specialty, or so and so person had no authority to do whatever they did. So if that communication becomes better, I think this whole issue of privileging can be sorted out to a certain extent. The other end of the spectrum is self-proclaimed doctors. So we see doctors who have taken a 6 months fellowship and then declare themselves a diabetologist or an endocrinologist and are treating patients that they are not qualified to treat. However, patients don't know this. They go there and it's only when there is a death or an adverse event that they either go to the court or they seek, some kind of reference from some other specialty. So yes, privileging is required, and we know that working with patients, we know that there is a severe shortage of doctors as well as nurses and pharmacists, and that certain specialties do need certain skills that need to be practiced. But we need some transparency in this practice, and as Dr. Agrawal said, we need a repository of these doctors so that if I'm searching the web, I know which doctor is qualified or specialized in a particular area, so that I'm able to choose the right doctor, because that's my right to choose the right doctor as a patient. In the current scenario, we do not choose. We just go to the hospital and we are given a doctor who we think is the best doctor for us. I think that's where the discrepancy is. And several times that doctor may not be the right doctor, especially if it's a standalone practice or a small practice in a tier 2, tier 3 city. So I think, in the larger scenario where we are talking about how the law can be put into place to bring more specialities and more qualifications so that we have better outreach to patients, we also need some kind of regulation so that people who are self-proclaiming can be brought to, the current level of medical law or whatever it is, so that people are not misusing the qualifications that they have, and they are not putting the patients at risk just because they want to earn more money. I'll just stop there.
I think that's brilliant. You've given me a brilliant idea. Maybe under the Akhil Bharatiya Digital Health Mission, maybe it's time, like with our banking system, where I put in my disease, translate it from voice to text. It goes to the ABDM, and then subsequently the doctor is selected, and then I get an OTP saying, "Is this the right doctor or no?" Because that's what happens with banking. That's what happens with my Swiggy. So why can't I do it with an important part of my life, my doctor? Probably something to look forward to. That's just on a lighter note. I think it's extremely important what you said. It is the doctor who pulls down the doctor, but then to that end, we are all Indians. We all know the story of the Indian crab. Nobody allows anybody to get out. Thank you very much, Dr. Ratna Devi. I would like to again listen to one more voice of the patient, non-governmental organization, Dr. Dhwani Mehta. Dr. Dhwani Mehta is the co-founder of the Vidhi Center for Legal Policy, an independent think tank based in Mumbai, Delhi, and Bengaluru, which is into legal research. My own point of view is that these are important organizations. They make better laws. They help to make better laws and improve governance for the public good. Dr. Mehta leads the organization work on health and medical law and policy, and she has worked on pharmaceutical regulations, organ transplantations, grievance redressal mechanism, and rights-based approach to public health organizations. Also closely involved with work on end-of-life care, which is something that is still being footballed around as we speak. Also on advanced medical directives and to simplify the procedure to withdrawing life-sustaining treatment. Thank you very much for this brilliant social work, Dr. Mehta. Dr. Mehta, your own views. How do you think privileging is going to help our patients? Advocate Bajpai, I think, Dr. Mehta, I'll just intervene. Something important, Advocate Bajpai? No, okay. Dr. Mehta, over to you. How do you think privileging this is going to actually help patients, is actually going to have safer, more transparent healthcare in the country? Ma'am.
Thank you, and thanks for inviting me to speak today. I have to confess, this is not an issue that I was very much in the know about. So I've only come up to speed after reading the concept note and some of the cases that Mr. Ravindra shared with me. So thank you for opening my eyes to this particular problem. I have a few preliminary conceptual thoughts. So because I can't really speak from experience, I'm just going to speak about this as I would approach a legal or policy problem. So from the cases, at least, that I went through, it seemed to me that the issue appears to be either the inability of courts or consumer fora or other, bodies where these issues are litigated to recognize what
No, I
it
just
means.
wanted to tell you, you gave a good new startup idea.
Okay, fine, sir. Dr. Mehta, please continue. Sorry.
Sure. No, it seemed to me that one of the issues appeared to be that courts are not able to assess correctly whether skill in a particular discipline or a specialty allows you to practice across a range of specialties as well. So one is, I think, and perhaps this is and this is where privileging, if it's done in an appropriate authoritative manner, might help, is to guide the courts in arriving at this decision. And it's not just in general, I think, from some of the research that we've done, that it's the sort of inconsistency with which sometimes judicial bodies tend to approach issues like medical negligence. This particular issue that we're discussing today appears to be one instantiation of that. So
can I request the rest of you to kindly mute yourself? Dr. Mehta, please continue. My apologies.
Sure. No problem at all. So if if courts are genuinely making mistakes in, making pronouncements about what constitutes medical negligence in terms of, an anesthesiologist not being able to perform something else, I'm just using broad examples and placeholders here, then there is the need to correct that, because, that causes uncertainty and, as you said, defensive practice, and actually reduces access to healthcare practitioners across the country, which are in any case in limited supply. So one potential use of privileging, as I see it, is to ensure that courts are able to take the right decisions about what constitutes medical negligence or not. The second, in terms of, how this contributes to patient information and awareness, I see it just, as a form of increasing reducing the information asymmetry that might exist. So for patients who are interested in knowing that the healthcare practitioner that they approach actually does have the skills and qualifications that they claim to have, then again, if privileging is done in the right manner, then that obviously contributes to greater patient information and awareness. But I have to confess that I am still not entirely sure about the distinction between privileging and credentialing. So to my mind, the real need is to ensure, if by credentialing we mean that we ensure that it's the process by which a regulatory body allows a certain kind of person to practice a particular branch or specialty of medicine and doesn't allow those without that qualification to practice, then that seems to be the problem that needs to be addressed primarily. I mean, if at all this is not being done appropriately. So, if the National Medical Commission has said that, someone with a BDS degree can perform certain kinds of surgeries, this kind of awareness needs to reach patients, it needs to reach courts, and it needs to reach other doctors as well. And this kind of credentialing, to my mind, can't have a distinction based on a rural or urban or public or private divide. So whether or not someone is qualified as possessing a particular degree or qualification to do something, that should operate irrespective of where they are to be found. Now the question, and this is, once we are clear about this particular issue, the question of privileging, to me, really seems to be one of, as I said, creating greater patient information and awareness, and perhaps acting as some kind of incentive for medical professionals, in the same way in which we have, accreditation and quality improvement for hospitals. So if privileging is only about ensuring that some persons can lay claim to holding a particular skill without saying that only these persons can actually perform certain kinds of procedures or carry out certain kinds of treatments, then that really is a question of, to me, it's a quality accreditation kind of question. It's not really, it doesn't go to the heart of whether someone is qualified to perform something or not, but whether they are allowed to represent themselves as holding out that particular skill or not. So I feel conceptually, if we have that kind of distinction, then then the approach to how we look at credentialing and privileging also will be clearer. I'll just give you one, to round up, I'll give you one example of where something like this might have practical application related to an area that I work on, which is end-of-life care. So as you might know, the Supreme Court has said that you can legally withhold or withdraw treatment from terminally ill patients, and that this has to be certified by 2 medical boards. These medical boards have to comprise a treating physician and 2 subject experts of the concerned specialty. So this is not, I mean, we will end up having some kind of debate, I think, on what that specialty means, who can be included in that specialty, who can we say has expertise in critical care. I would just, and again, this is, while thinking about these questions, it's important to keep in mind that issues about this kind of end-of-life decision-making have to be decided at all kinds of hospitals all throughout the country. So it's important not to define these subject experts so narrowly that you lose the ability to take end-of-life care decisions in a responsible manner. So that's just one area in which I thought that this kind of discussion might have some practical relevance as well, and something to keep in mind while we continue our deliberations. Thank you.
Thank you very much, Dr. Mehta. I think that was crisp. I sometimes believe Pandora was born in India, and you opened up a very important aspects. If we were to look at granting privileges on the basis of credentials alone, it raises a very important point on the ability of medical councils to get into what we call at all our accreditation bodies, the primary source verification. Do I know that Dr. Parag Rindani got his degree of a copy shop at Malad, where he lives, or did he actually go to college? And is the college willing to certify and sign off on that? I know we're talking about IoT and blockchain, and at some stage our degrees are going to get into that. But I think the relevance is whether medical councils who grant licensure are actually able to sign off and say that, yes, I'm granting a license because this individual did go to this college and I've spoken to the dean of the college. He's verified, they have verified these documents, and therefore that's what we're signing off on. Then automatically the privileges that flow to such a appropriately quote unquote verified quote unquote professional are exactly and absolutely on dot. So thank you very much to bring that up, Dr. Mehta. And now over to a person whom I respect tremendously, a person who works in an institution we all respect tremendously. Professor Mariyappan is a professor at the Center of Hospital Management at the Tata Institute of Social Sciences, Mumbai. Personally, we are grateful because he's churned out dozens and dozens and hundreds of hospital administrators who are today leading institutions, has worked on a number of hospital development projects. Professor Mariyappan, as a professor, as a teacher, as an academician, your views on how do you think privileging is going to actually impact Indian healthcare? How do you think it is going to help you to churn out better healthcare professionals? Over to you, Professor Mariyappan. You have 3 minutes, sir.
Thank you so much for giving the privilege to speak in this forum.
That's an important thing. You have been granted a privilege. Thank you so much, sir. Please continue.
Right. We have got a number of case studies where our PG students and PhD scholars used to work on this credentialing. We have not done much work on the privileges. However, when we looked at consulting and various other research projects, we've seen privileging is a very important aspect where we look at the specialization and their expertise. Accordingly, the privileges have been given. For example, we can say OPD. In OPD, some doctors would like to come for only OPD. They are given the privilege to see OPD patients. Some of them wanted to see inpatient and selected patient who are admitted in their name or registered in their name. Someone would be particularly full-time doctors who can see any patient, who comes to the hospital. So like this, the system has been established in many of the hospitals. I hope all of you are aware. Now, our point of view, when we have to take up this as confirming the operational definition of privileging or taking this privilege as a broader framework or policy level, some of the key issues which we need to look into. One is, there are already everybody addressed that. I'm only reiterating. One is the infrastructure, facilities, and location, that one aspect. The second major concern is how far this privileging is promoting the patient care process, patient-centeredness, and patient safety, and also looking at the patient need as the central point. The privilege has to create an atmosphere, an environment that the doctor is able to understand the patient needs in order to use their skills and competencies. Second, privileging has to promote the transparency, accountability, and even autonomy to the doctors. So when it comes to, many times we talk about competencies and skills, accordingly giving the privileges, sometimes it will reduce the autonomy of the doctors. So we need to see that they are highly empowered. Time to time, they are given opportunity to utilize the given chances. That is one. I'm afraid that when we go into too deeper of privileging, working on integrities, it may reduce the medical professionals. Sometimes it may demotivate also. So far, we have got so many regulations which are already being done. The problems, negligence, malpractices, time to time it may happen. There are certain situations. But overall, common platform and perspectives, we must promote their interest of doing certain good work. In fact, privileges also should promote their future research and contribute to the medical profession more and more. In fact, a high level of PhD and other higher level of research, you still like to take much in medical profession. So encouraging, giving much privileges would always help. Only two final points, two words. That is, one is institutional level, they have to have an appropriate record on their continuous competency development of medical professionals, not continuing medical education. It is a continuous competency development program. Second is that promoting autonomy, empowerment, and freedom to the doctors, how far it is being achieved. A doctor feels that I do well, I can do this. That's the way we have to take. So with this, I don't know, I offer, because all other very closely in detail, everybody contributed. but I can only bring this point based on our observations broadly about healthcare industry. Thank you so much for giving this opportunity to speak to this.
Professor Mariappan, thank you very much. I think it's the entire genesis of this discussion is to be able to certify and to actually put on record whether he, she, they are able to actually do things as they themselves feel well. Thank you very much. We've completed a fair cross-section of our participants. We've spoken to our doctors, we've spoken to the patient care details, and we now move on to the next section, and that is the policy makers. As we move forward, I'd like to first of all invite Ms. Vasudha Khanna. I'm sorry, but is Ms. Khanna there? Ravindra? No.
No, it doesn't seem like Parag.
No, I don't think so. Okay. I had a confirmation on my screen. That's the reason. Okay. Without further ado, I'd like to invite the extremely patient and extremely diligently listening Dr. Krishna M. Arya sir. I think he's locked in from the beginning and he's heard all the arguments, pros and cons. Let me introduce, before I request Dr. Krishna Arya sir. He is the Deputy Legal Advisor with the Department of Legal Affairs, Ministry of Law and Justice. He has been the legal advisor to various ministries, departments, including the Ministry of Health, Department of Commerce, Ministry of External Affairs, Department of Space, etc., and was also deputed as a legal expert of the Government of India to serve in the Government of Seychelles. Dr. Arya sir, welcome and thank you very much for diligently and patiently listening in. Your views on medical privileges or privileges to medical practitioners, doctors, how do you think we can go about it? What is the need? And how is it going to impact patient safety? Dr. Arya.
Good morning and thank you to all panelists and learned judges and advocates. I have worked with the Health Ministry last 1.5 years, and now I am handling Department of Commerce. The policy concern is that the health is an state subject. Central government can have a broad framework for guiding the states, and the role of medical councils and state authorities and local authorities are very crucial in this regard. There are a Clinical Establishment Act and HOTA and Drugs and Medical Devices Act. The doctors are dependent on the drugs and medical device. So their duty to take cares and negligent part are also be taken care in that context. Sorry. And after listening to all the esteemed panelists, my view is that while the government, whether state government or central government, making rules, these bodies and individual and experts should play a very proactive role so that the things will come on the platform. So the rules will be effective and implemented accordingly. This is my personal view and not to treat it as my department view. Thank you.
Thank you very much. I will just check in and see if Dr. Arpita Agarwal can join us in case she's free. She might not be available. Dr. Agarwal is a consultant public health administration with the National Health System Resources Center, an experience of over 8 years working with various corporate hospitals with international exposure, and has contributed in both public health as well as legal domains. Dr. Agarwal, are you able to hear us and join us?
Sir, I'm very well here and I am joining. But then from our NHSRC side, I would just say that we will reserve our comments for later. So probably we would send in our comments later, sir.
That's perfectly fine, Dr. Agarwal. That's very much you're right.
Thank you,
But do send it in because we do respect the experience and the expertise that you bring to the table. So we'll be very honored to receive your inputs towards this white paper, ma'am. Yeah.
Sure, sir. Sure.
Thank you very much. Thank you. I just wanted to double check with Ravindraji whether we have Major General Professor Kotwal and Dr. Garg. Are they with us today?
No, unfortunately, they have not been able to join because of
Okay.
some other commitments.
Okay. So essentially, we've heard the plaintiffs, we've heard the defendants, we've heard all other potential contributors to this extremely complex and but much needed debate whether we can how we can look at granting privileges. We probably would need to answer more of the W's and the H's in terms of we've understood the why, we probably know the where and the when. The only question is how do we do it, and how are we going to be guided in this by our esteemed justices, and our judges. So without further ado, so that we have some time towards the end for any comments or discussion points that our honorable justices may raise, may I first invite Honorable Dr. P.C. Gupta, former member judge of the National Consumer District Redressal Forum for more than 5 years. During this period, he headed a bench dealing with medical legal issues for a considerable period of time. He's also a former principal secretary of the Government of India. Honorable Dr. Gupta, sir, over to you, sir.
Thank you very much. Thank you, Mr. Bajpai. Thank you, Mr. Ravindran. Having listened to the views of the honorable speakers, I am doubly convinced that in a country like India, some kind of system has to be built. Some privileging has to be done. So who is to do it? What is the manner in which it is to be done? I have certain specific points for deliberation in this forum, which I will say one by one. But before that, let me say that at the moment it appears, maybe I'm wrong, but there doesn't appear to be any system at all. Because day in and day out, we find even in very big hospitals, in big cities also, Ayurveda doctors managing the emergencies, especially at the night time, we see on a daily basis. And then one more example, when I was in the National Consumer Court Commission, I was hearing a case, one Ayurveda doctor posted in a remote rural area of Madhya Pradesh. He performed a cesarean section upon a lady. Something wrong was there. So during the course of hearing, I asked the doctor, why have you done it? So he told me, sir, in that 15 to 20 kilometer of radius, I was the only medical professional available. The lady came to me in a very precarious condition. Had I not done anything, even then you would have blamed me. So this aspect leaves many things for clarification. Privileging has to be India specific, has to be institution specific, and more so area specific. Somebody may have a privilege to do something in one place, maybe in a rural area. He may not have the same privilege in an urban area. Even in urban areas, there may be two different hospitals. He may have a privilege in one hospital. He may not have privilege in the other hospital. So what is required to be done? To my mind, there can be two approaches in our public administration. One is a top-down approach, that you lay down the law first and then start implementing it through courts, through bureaucracy and all that. The other is the bottom-up approach, that something gets done, something emerges from the bottom. So when I say bottom-up, what do I mean? To my mind, our medical professionals in India, they are fully committed, they are fully capable, they can take charge of the system, they can lay down the policy, and the lawmaking can come at the last level. I will come to it later. So the point is, you have how to do it. I will not say only the regulator should do it. So all over the country, at the city level, district level, state level, national level, every specialty in medical practice, you have the associations, you have the federations. So let there be deliberations during the meetings of those associations. In every conference, let there be a session on credentialing and privileging. So when discussion takes place, something will definitely emerge out of it, and that will be a guiding force. Somebody said courts are not able to understand. So that will be a guide for the courts. So I think I'm very clear about it. You have to have the input from the honorable medical professionals who are fully committed to do it, and they can very well do it. So far as courts are concerned, law is very clear. Who lays down the law? The Honorable Supreme Court of India. The Honorable Supreme Court of India, not in one judgment. Mr. Vajpayee quoted Samira Kohli, that was on by the Honorable Justice Ravindran on the informed consent. Honorable Supreme Court of India has laid down in hundreds of judgments that whatever is done by a medical professional as per the established medical practice, there is no negligence. A person may die, a person may suffer from disability, but if something done, that is called Bonum test, something in technical language we call it. Now, the Honorable Supreme Court says that established medical opinion says no negligence, the court will say no negligence. If somebody is deviating, the facts and circumstances may be different, but this is the law of the land. So I don't think that you need to make a law in the beginning. Let it not be done by the bureaucrats sitting in the Nirman Bhavan or in the law ministry or the honorable lawmakers sitting in the parliament. It has to be done, from the stakeholders who are the medical professionals in this case. Let it be India specific, let it be for urban areas, let it be for rural areas. So they have to lay down the norms. They have to guide everyone else in the society, the general public, the lawmakers, the law enforcers, the courts. They have to do it. And I'm sure if they decide like this, if this session organized by IML, based on the recommendations, if something starts, it will be a great beginning for this country. And let us hope for the best for the coming times. Thank you so much.
Thank you very much, Dr. Gupta sir. I think you have nailed you've nailed it. You've laid down the basis for our white paper, that there needs to be inputs from the various organizations. For example, for gynecology, we have FOXC. For gastrointestinal surgeons, we have the IAGES. Of course, we've got the overarching blessings of the Indian Medical Association. And we've got supporters across from all the medical councils. We've got doctors sitting there, and I think a lot of inputs can come in from there as we move to build it bottoms up. I think that's what our nation needs. Thank you very much, sir, for those valuable words. I now request Honorable Justice Ajay Kumar Mittalji, who is the former Acting Chief Justice of the Punjab and Haryana High Court, former Executive Chairman of the Haryana State Legal Services Authority, former Chief Justice of the High Court of Meghalaya, and then Madhya Pradesh. He is on the Board of Governors of Chitkara University currently. May I request Honorable Justice Mittal sir to kindly give his views on how he feels we can build this humongous and gargantuan kind of structure in the country so that we come at par with anybody in the world. Over to you, Honorable Justice Mittal sir.
A very good morning to all. I am truly honored to be here today amongst this august gathering of distinguished medical professionals, legal luminaries, and other respected dignitaries through digital assembly. I am glad to know that Institute of Medicine and Law has organized 8th Medical Convention on Medicine and Law 2023. I must compliment the organizers of this convention for their determined and implacable efforts for making this event a great success. The main objective of this convention is to discuss legal issues relating to medicine, legal definition of privileging, what should be the policy for special privileges, problems, and solutions associated with privileging. The privilege to practice medicine is not merely a right, but a profound responsibility that demands the utmost dedication, proficiency, and integrity. Medical privilege is the cornerstone upon which our healthcare system stands, ensuring that individuals entrusted with patient care possess the necessary qualifications, experience, and ethical standards. It is imperative that this privilege is granted judiciously, with thorough scrutiny and due diligence. In the ever-evolving landscape of healthcare, the demand for competent and qualified medical practitioners and professionals has never been higher. However, the significance of expediency in granting privileges must never overshadow the necessity for stringent evaluation. We must strike a balance between efficiency and meticulousness in the privileging process. The consequences of hasty decisions in privileging can be dire. Patients' lives are at stake, and any compromise in the vetting process could lead to substandard care or even irreversible harm. Therefore, it is incumbent upon us to streamline the evaluation procedures while upholding the highest standards of scrutiny. Furthermore, the advent of telemedicine and online healthcare services has added complexity to the evaluation of medical professionals. While these technologies have extended the reach of healthcare, they also necessitate a reevaluation of how we assess and grant such privileges in this digital era. Robust mechanisms must be established to assess practitioners in virtual care settings without compromising the rigor of evaluation. Addressing issues relating to privileging in medical practices requires a multifaceted approach that prioritizes patient safety, maintains high professional standards, and streamlines the evaluation process. Here are some potential solutions which I have summarized under 8 headings. First, 1I, standardized evaluation criteria. Establish comprehensive and standardized criteria for evaluating the qualifications, competence, ethical conduct, and experience of healthcare professionals seeking privileges. This criteria should be regularly updated to incorporate advancement in medical practice. 2I, robust vetting process. Implement a rigorous vetting process that includes thorough background checks, verification of qualifications, peer reviews, and assessments of clinical skills and ethical conduct. This process should be consistent across all healthcare facilities. 3I, continuous professional development. Encourage and mandate continuous education and professional development programs for medical practitioners to ensure they remain updated with the latest medical advancements, technologies, and ethical standards. 4I, technology integration. Adapt privileging processes to include assessments of proficiency in telemedicine and digital healthcare delivery. Incorporate technological advancements in the evaluation of healthcare professionals practicing in virtual settings. 5I, transparency and accountability. 6I, collaboration and best practices. Encourage collaboration among healthcare institutions, regulatory bodies, professional associations, and legal entities to share best practices, guidelines, and standards for privileging. 7I, regular audits and reviews. Conduct periodic audits and reviews of privileging processes to identify areas for improvement, address by any shortcomings, and ensure compliance with established standards. 8I, public awareness and participation. Educate the public about the importance of privileging in ensuring quality healthcare and encourage patient involvement in the evaluation process, such as feedback mechanisms regarding the quality of care received. By implementing these solutions, healthcare systems can enhance the credibility and integrity of privileging processes, thereby promoting patient safety, maintaining high standards of care, and fostering trust in the medical profession. I now advert to legal position in this regard. I intend to refer to 5 or 6 important pronouncements which are of importance for today's discussion. It has been consistently held by the courts that the standard of care which is expected of a medical professional is the treatment which is expected of one with a reasonable degree of skill and knowledge. A medical practitioner would be liable only where the conduct falls below the standards of a reasonably competent practitioner in the field. Medical negligence jurisprudence in India is characterized by a reliance on the Bolam test. That is the first judgment which was dealing with this regarding medical negligence, where the Queen's Bench, for failure to administer muscle relaxant drugs and using physical restraint in the course of electroconvulsive therapy, it was held that the doctor is not guilty of negligence if he had acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art. It was further held that a man need not possess the highest expert skill. It is well-established law that it is sufficient if he exercises the due skill of an ordinary competent man exercising that particular art. It was further clarified in Bolam's case that the standard imposes a duty on medical professionals to ensure that obsolete methods are not employed. The next case on point was regarding Jacob Matthews case, where the three-judge bench of the Supreme Court reiterated the same principle, then a two-judge bench in 2010 in Kusum Sharma's case. Again, it was expressed in the same terms. But the latest was in a recent decision, the Supreme Court on 19th of October 2023, wherein the law on medical negligence has been discussed right from Jacob Matthews case, has inter alia held that it is our bounden duty and obligation of the civil society to ensure that the medical professionals are not unnecessarily harassed or humiliated so that they can perform their professional duties without fear and apprehension. The three essential ingredients in determining an act of medical negligence are a duty of care extended to the complainant, breach of that duty of care, and resulting damage, injury or harm caused to the complainant attributable to the said breach of duty. However, a medical practitioner will be held liable for negligence only in circumstances when their conduct falls below the standards of a reasonably competent practitioner. To hold a medical practitioner liable for negligence, a higher threshold limit must be met. This is to ensure that these doctors are focused on deciding the best course of treatment as per their assessment, rather than being concerned about possible persecution or harassment that they may be subjected to in high-risk medical situations. Therefore, to safeguard these medical practitioners and to ensure that they are able to freely discharge their medical duty, a higher proof of burden must be fulfilled by the complainant. The complainant should be able to prove a breach of duty and the subsequent injury being attributable to the aforesaid breach as well, in order to hold a doctor liable for medical negligence. On the other hand, doctors need to establish that they had followed reasonable standards of medical practice. In the end, once again, complimenting the efforts of the organizers, I wish them all the success in their future endeavors. Thank you so much. I'm so grateful.
Thank you, Honorable Justice Mittal, sir. I think that was extremely concise and extremely focused points of view put forward. I think we move on to Honorable Justice Manmohan Sareen, sir, who is the former Lokayukt of the NCT of Delhi, a former Chief Justice of the High Courts of Jammu and Kashmir, former Judge of the High Court of Delhi. He has also headed a tribunal constituted under the Unlawful Activities Prevention Act 1967 in respect of following organizations: ULFA, Bodo, NSCN, and the Deendar Anjuman, Chairman, Coffee Poser Board, and has played a major role in setting up the Delhi High Court Mediation and Conciliation Center and successful training of over 300 mediators. Thank you very much for joining us, Honorable Justice Sareen, sir. It's a privilege to have you here today. You have, you kind of have the what should I say, the privilege, quote unquote, of having heard everybody. You are therefore, you have the wisdom of hindsight today, or the, what should I say, the privilege of hindsight today. You heard all of us speak, the doctors, the policymakers, our honorable justices, your views on privileging, the necessity in India / Bharat, the way we're going to roll it out. Over to you, Honorable Justice Sareen, sir.
Good morning, my honorable. It is indeed a pleasure for me to address this august gathering. My task has been made easy by a comprehensive written text which Brother Mittal read. So he has dealt with almost all the contours, given you a specific paper to proceed with. And I, although have a written text, but I have chosen not to go by it and address you otherwise. Let me start by saying my claim or my privilege to address this gathering emanates from three aspects of life, as I put it. First, I will deal with my experience as a lawyer of handling the medical negligence case and what difficulties one faced. The second is in the judicial career when I gave few judgments which were, I shouldn't use the expression path-breaking, but were a wake-up call kind of thing. And the third has been, I have been the managing trustee of a charitable trust for the last 16 to 18 years. We ran a polyclinic cum nursing home, wholly charitable, and therefore I had a lot of interaction with medical professionals. So I bring to the table some insights from these three sides, which I hope you would give me the pleasure of listening to. Let me start by saying, and my focus is going to be different on an issue which you people have not yet considered. You see, every day medical professionals blame litigation in courts, prosecution, as also being a major contributor to defensive medicine. I am today going to ask you, my friends, take a peep inside, do some introspection. Is that the only reason? I mean, let us see. I recall my old times in the generation of yesteryears. What was the belief? How was a general physician treated? He was treated as a messenger of God, sent as a savior to relieve us from disease and pain. He was treated with utmost reverence. Mishaps, casualties, or failure of treatment was passed off as a will of God. There were no complaints. What was the reason? The reason was existence of abundance of trust, mutual trust between the patient and the doctor. Now you must recognize what has happened. This trust has become a victim of what if I am permitted to say, commercialization. Commercialization in medical field. Now, a doctor knows patient A. He goes to the table and operates him, that's fine. He has got the competence, he has got the expertise to it, he is doing a job, he is doing 10 surgeries a day, but there is no individual contact. I remember the old time cardiologist, he would visit the doctor and say, I am narrating an old incident, it came to my mind, my father was ill, and there was one Dr. Prem Sokti. Not that he was a very great cardiologist of him, but he would come and say, sir, you are looking great. How are you feeling? That was half the cure. He would say, no, let him shave, let him be ready. Encouragement. Today, the professional does not have the time for it. The era of old general physician, family physician has disappeared. I don't know whether to what extent this is contributing to defensive mechanism. Now, I'll tell you, as a lawyer, I filed long time back in 79 a case of negligence, and the person involved was a gynecologist. It was a clear case of post-maturity, right? The gynecologist kept on waiting. The fetal heartbeats she couldn't hear properly, or she was in distress. The real reason was this person had built an aura around her of being a very capable obstetrician, but the fact was she hardly had done ever any cesareans. The patient required a cesarean. She was dithering, waiting, inducing labor, saying, forceps, let's wait. It didn't. And at that time, the child died. So we filed a suit for negligence. Now, the point I'm making here is this. At that time, the patient tried hard to get evidence. Now, at that time, it was the consumer forums were not there. The Consumer Protection Act had not come into being. You had to go to a civil court. Sorry, I see some sense of whether I'm taking long or not, but this is an aspect which you people have to be aware of. We tried hard. The patient tried hard. Every doctor, he went with the record, showed him this is the period she waited, and this was the fetal distress till the child stopped breathing. Everybody said it's a case of gross negligence. He said, sir, would you give an opinion? Not a single medical doctor was willing to come and say something against anyone else in the fraternity. So at that point of time, I filed this suit, we carried on. I said, we will live with I will go. And as a matter of fact, I still remember I went through a complete your Bible on obstetrics. After 3 months, I could feel I could deliver a child. You know, this is the kind of effort you have to put in. Then coming to the second part, as a judge, now I'm pointing out another incident to you. The purpose of pointing out are these are the anomalies which need to be corrected, which we need to self-correct, not essentially doctors, the system needs to correct them. Now, you would be aware, there was a writ filed before me, it came up. The patient was suffering from liver cirrhosis. He needed a liver transplant. He was admitted to the most reputed hospital of Delhi, and they would not do a liver transplant for a simple reason. They said HLA typing is not matching, and therefore the definition of near relative under the Transplantation of Organs Act is not met. Now, if he is not a real near relative, we will not do the liver transplant. Now, sir, see in practical terms what has happened. 15 days of stay at the 5-star hospital had already accumulated a bill of about 12 lakhs. Patient was at its end of resources. He came and said, here is I am related, here is a certificate from the village sarpanch, here is a certificate from the local MLA that this is the father, this is the child born, and I am the brother. This should be accepted. At that time, I looked at it, the rules under the Act and that. I passed the rule which said that HLA typing was also required. And at that time, I took the opportunity of doing some research. And I looked at the existing procedures in about 20 jurisdictions around the world. For a liver transplant, it is not necessary to have a near relative. All that is required is a healthy liver. Now imagine something so basic. And the tragedy was the patient died. By the time we had given permission, told them to go ahead with this, the patient had died. Now, fortunately, you will be happy to know, I didn't leave the matter at this end. I appointed a committee and they went over the Transplantation of Organs Act, and the committee made recommendations, and those were accepted, and the act has been amended, and the rules are amended also to that extent. So this is at times the contribution of the judiciary also to the development of law in the positive side. Now, sir, coming to the third experience, running in the charitable hospital, in those days, the medical termination of pregnancy used to be not only by pills, it was a procedure done. Now, judges, I must admit, are very careful about their own reputation. So another brother judge who was at that time the managing trustee, he said, no, brother, we will not do any MTPs in our hospital. You know, every day something could come, you know, an underage abortion might be done of a minor, and our reputation could be at stake. So we were not doing these MTPs. Then one day I came across a case, a poor lady, she already had 4 children and she wanted an MTP done. So we said, sorry, we don't do MTP. You go to Safdarjung or go to Mary Stopes. There's another clinic. Now, a factual position I'm telling you, 2 months back, when I visited the hospital again, I saw this lady and I could see the advanced stage of pregnancy. So I called our head nurse. I said, what has happened? Why she didn't get the abortion? So she called this lady, and you know what she told me? She said, sir, I could not collect 1100 rupees to get the abortion done. I had gone to Safdarjung Hospital. I could not get a place. So what happens? I'm pointing it out. This example I'm giving for a purpose. The purpose is this: to be alive to ground realities. These are the teeming millions with whom we are dealing. For 1100 rupees, which she couldn't get, Safdarjung couldn't take her, and Mary Stokes' charges were 1100. She couldn't afford it, and she brought a child into this world whom she can't look after and she can't really make grow. See what is the stage of our country at this time. I mean, today we talk of having grown, fine, but this stark reality is not changed. So what we need to see, it is in this background that we have to evaluate our actions, what we do. Now, that's how I put it. The lack of medical professionals available as against the teeming millions to be treated, commercialization of the medical profession and services, high costs have all contributed to heightened expectations. Now, I want the doctors to ask themselves a very simple thing. Sir, a person has a simple fracture of the ankle, of the foot. You do an X-ray. It would cost about, in a good hospital, 2000 rupees or so. X-ray is done, it shows the fracture. The treatment is a plaster for 21 days. Everyone knows that. There is a ligament injury also. What is the treatment for that? Same plaster. But the doctor says, all right, have the MRI done also. MRI would cost you 10,000 rupees. What is the fate of a patient? Those who can afford it, wonderful. Or those who have reimbursement, excellent. But those who don't have it, they have situations where they have sell their property, their land to get the treatment done because life is first. Now, sir, I ask this question. This evaluation, after 21, I asked an orthopedic friend, I said, tell me, this damage to the, what do you call that, Dr. Sahab? Apart from the bone, the ligament. The damage to the ligament, could be seen after 21 days also? If we see it after 21 days, if there was no treatment to be given, it will be the same, the healing will be there. So the non-necessity of tests and procedures. Now what happens? I'm being very blunt today. I'm being outspoken. I hope you will excuse this. The hard reality is this, that most of the professionals in doctors, in establishments, they have targets. The commercial hospitals give targets. This is the target you have to meet. And so you are meeting the target. Well, it is desirable to find this out. So it is good to do so. So, sir, this on the point of what I am saying is, the defensive medicine is not only being caused by any decree of the court or a court holding you up for negligence. There are other reasons also for it. We have to look at and correct that aspect. Now, coming to the present setup, my own view is, after having heard all of you on this, that look, Justice Mittal has succinctly pointed out 8 pointers. The 2 things I want to clarify are this. Legislation has to be done, law is to be made by the legislature. It is not the courts. The courts interpret the law. The courts fill up the gaps. The courts fill up the void in the law. We fill up any lacuna that is left up for the time being. It is not that we legislate. Legislation has to come from the parliament or the state assemblies when it's a state subject. The feedback has to come from all of you. And for that, as what we need to look at it is, as Mr. Gupta was saying, collect this data, have it ready, and in this context, I would say these are very relevant considerations, privileging where you are located. You in Bihar or other places, if you see, all of you would have domestic servants. Ask one of them. The primary center is 15 kilometers away. They walk across. The district hospital is again about 80 miles to 100 miles away. So, sir, what is the point? Can we really have a privileging in the primary health center? Can we have privileging or so credentialing? Fine, basic qualifications are there. And coming to the part, I fully recognize and appreciate the agony of a medical professional when he is being arraigned and told, prosecuted for an unjust cause, especially when he had done all his best. You know, treatment does not mean ensuring treatment success of it. But at the same time, you know, some of these, we require a system within even the metros where you upgrade and constantly upgrade. I'll give you another instance.
Advocates, Justice Sareen, I'll request you to wind up in the next 30 seconds. Yeah.
Less than 30 seconds.
Yes,
I'm
sir.
just only telling you, I don't know how long I took. Maybe I was, you know, we accuse our lawyers very often of suffering from verbal diarrhea, but judges are also accustomed to it at times. I must admit it. So what I was telling you was, take a case of a surgery. What happens there is, in a case of oral surgery, oncology one, at times I found out, you know, there is a dye injected which will give an indication all over the different jurisdictions in the world, which gives an indication of any leak. But in India, we don't do it. We use the same color as one, so you can't make out if there's a leak. Thank you, sir. I would say it has been a pleasure listening to all of you. And my view is this ought to be introduced in stages. We are not ready for total privileging at this stage. It has to be situation-wise, location-wise, and based on inputs from all of you.
Thank you very much, Honorable Justice Sareen. And for the record, on behalf of all the doctors, I have Professor Dr. Utture, I have Kaho here. We just like to add one word to Honorable Justice Sareen, the word alleged to be added to this so-called targets that are given to doctors as the CEO of a small group of hospitals in Western
No,
India.
sir, sorry, sir. Let me say it last minute. Last say, judges always have the last word.
Of course, sir. With respect, sir.
You see, I did not mean that all doctors follow this practice of targets.
Of course. We
There
understand
are,
that.
let me tell you, I've come across excellent professionals, and they are today they are in a good number also. I must say, I have known why in our entire public system, healthcare, the doctors work on a paltry salary.
Of course, sir.
Right?
So,
and even in others, I have seen doctors who would not prescribe anything else, and they would come at any time of the day, night to look after the patient.
Yes, and I think we've seen some brilliant examples of the contribution of healthcare professionals, public health, and a lot of that during COVID.
Of
so
course.
we'll wind up there.
That's why our system is alive, because you have excellent professionals who bring duty before self.
Right, sir. I will request and move on to whom I would call a friend, philosopher, and guide of the National Convention on Medicine and Law, a person with whom I've had the privilege of interacting at multiple conventions in the past. Honorable Justice Ravi Tripathi, sir. Honorable Justice Tripathi is currently serving as the chairman of the Gujarat State Human Rights Commission. He has been the judge of the Gujarat High Court and also served as a member Law Commission of India. His views on laws related to medicine are heard and respected all across society. Justice Tripathi, first of all, on a personal note, it's a pleasure to see you again. I think we need to meet at least once in 6 months rather than this one-year thing that Advocate Bajpai puts us through along with Ravindra. We need to catch up for a cup of tea whenever we are in each other's cities. Justice Tripathi, sir, your views on privileging. Let's look at it holistically from a societal point of view, India versus Bharat. Doctors, good, bad, ugly, jaise bhi hai. The law, good, bad, ugly, whether we like it or not. There is a need, and can you just help us to quantify how we can stage this, how we can roll it out across society, sir? Over to you, Honorable Justice Tripathi, sir.
Good morning to everybody. Dr. Parag, it is nice to hear you after a good break of time. Friends, the judicial discipline says that when one judge has already delivered a judgment, the other judge just says, I concur, and puts his signature down. In my case, there were two predecessors, Justice Mittal as well as Justice Sareen, and they both are very dear to me. Their views were excellent, there's no doubt about it. But then we do have a section when we say that I agree with the earlier judgment, but then I also put in some inputs. In those inputs, I say first thing that the organizers have done an excellent job. And this was a very right topic which we are discussing today for such an important event. Friends, there has to be privileging, there is no doubt about it. But only thing is that Justice Sareen was rightly putting it, it is to be decided that at what stage, at what speed that we have to bring this particular in. You know, it can't be overnight that from tomorrow there will be privileging and everything set up is provided. That is not possible. So let us be very clear. And Dr. Parag, I really appreciate using those two terms, India and Bharat, and possibly that also makes a little indication to the prevailing political scenario also. There is India on one hand, there is Bharat Jodo Yatra on another hand, and those things are going on. But then anyway, in medical terms, of course, this is very, very important. What I feel is that when we start with the privileging, especially the lawmakers will keep it in mind that it has to have two standards, basically, one for the hospitals, those who are run on a corporate model, and they claim to have every single specialist available with them. For them, there should be a different standard. And when there are individuals, as Mr. B.C. Gupta said, that there was a case where the only Ayurvedic doctor was available within the vicinity of 15 to 20 kilometers. In that particular case, if somebody insists on privileging, that will not be possible. It will not be advisable. It will not be specific to India or our country, and therefore it should not be there. Friends, one thing is sure, that this particular privileging will help the adjudicating forums. It could be commission, it could be court itself, but it will definitely help them while deciding the question of negligence. I'm here to reiterate, which I have been reiterating in so many earlier conferences and gatherings, that basically judiciary or judges are not anti-medical professions. They are not. They also, looked at them with a very good respect. Only two difficulties are there. One is that the personal touch has gone. Earlier, we used to have a family physician and who used to guide us to go to any particular specialist or to any particular hospital or to any particular special treatment. But that particular thing is lost, and that is a loss of every one of us. That is very important. Second thing is that there is a lot of commercialization, and it is rightly referred that we hear so many things about targeting by the corporate hospitals, and that target given to them, when it is tried to be achieved by the doctors, there are difficulties, there's no doubt about it. What I think is that doctors should try to see that even when they are in a particular corporate hospital, whenever they go to that particular patient, whosoever is attending to that particular patient, they should give little personal touch to that. And I remember in a court of mine, when I was having a person to be examined, I just asked him, "Aapke gaon mein kaisa hai?" And he was so much, happy about it. So, sir has asked me about my village and my family. So that sort of personal touch should be there. I'm not saying that it should be at the cost of the medical treatment, but at the same time, that personal touch is required. Second very important thing is that we are in a stage where we are in a developing stage. And in that developing stage, to expect everything according to the Western world countries, developed countries, that will not be befitting. we must be very careful and we very must be mindful that we have typical circumstances in the country, our literacy rate, our understanding rate. I like your comment that there should be something like, on mobile you put my doctor and my treatment. I think that will be excellent. But then that time is yet to come and we have to wait for that particular thing. I think today's discussion was very nice. All inputs were excellent. And especially Dr. Ratna Devi, then Dr. Dhwani Mehta, who candidly admitted that she did not know about the subject so much. But then from the input, she is able to make comments. And one thing is certain, howsoever hard you try, the difference between the rural area and urban area will not be able to gap up so easily. That will continue to be there. And the legislators will have the extra burden on them while framing any law that they should keep that particular difference in mind. I think that's excellent. I shall thank the organizers for this and see you again some other conference. Okay, thank you very much.
Thank you very much, Honorable Justice Tripathi, sir. As always, it's an honor to hear you. We are coming to the end of this, and as we get into the winding up mode, and before I step down from the temporary privileges, that's also a concept, temporary privileges granted to doctors. As I step down from the temporary privileges of moderating this wonderful session, I'd just like to place on record my thanks. And I personally love to quote one particular quote from Sanskrit. Anna danam param danam vidya danam atah param anne nakshanika trupti ya vidyaya jivacha. I just wanted to say that it's always a pleasure when we are able to not give a man fish, but teach him how to fish. And today, I think you have laid the cornerstone, the foundation for this white paper, which is going to help us. This knowledge is going to help us. Yes, Honorable Dr. Gupta, sir, I'll come back to you, sir. I think I will hand over the microphone before we conclude back to Dr. Utture, but on a personal note, thank you very much. There will be a Q&A and comment session, and Honorable Dr. Gupta, sir, Ravindraji, please make a note that sir is given an opportunity to speak at that point in time. Unfortunately, the privileges granted to me by my better half include the fact that at 12 noon sharp, I am expected to, like Cinderella, disappear into an in-laws luncheon party. So with due apologies and a load of gratitude, I'd like to sign off. Over to you, Ravindraji, and subsequently Dr. Utture, sir.
Thank you so much, Parag. It has always been a pleasure to have you as the moderator. And from the bottom of our hearts, thank you very much.
Thank you. With due permission, I will take leave, sir. Okay.
Have a great day.
Thank you, sir.
Okay, coming back to Dr. Gupta, you wanted to add something before we move on?
Just one line only, a very specific suggestion that we talk of a credentialing and privileging committee. To my mind, they are not existent. Let us make a beginning. Let us take some 50-bedded hospital or 100-bedded hospital, anything beyond that. So let us make a recommendation that every hospital 50-bedded and above, let there be a credentialing and privileging committee. Let us make a beginning, and then the things will further emerge.
Absolutely. That's a wonderful suggestion, Dr. Gupta. Thank you so very much for that. And I now hand over the proceeding to Dr. Shivkumar Utture for the summing up of the session. Dr. Utture.
Yeah, thank you, Dr. Mangal. I think Dr. Vijay Agarwal has put his hand up for something.
I will just say, allowed to put just 1 minute. We saw a lot of discussion, in fact, going away from privileging. And I feel that sometimes our learned justices and all that, there is a huge talk about the commercialization of the medical practice. And I think there may be a separate kind of a discussion maybe on this particular topic, so as to understand. I think there is a lot of naturally talks that we do about how a practitioner in our time used to kind of react and act. It is just like how we were treated by our parents and grandparents, and today how I see my grandchildren addressing their parents and us. So there is a huge generational shift in the way the whole society is kind of functions. But what I'm saying is this is a very, very important point which is occupying the minds of most people regarding the so-called commercialization, and I will say that should bring us also to the economics of healthcare. So at one stage, I will request the organizers to have a separate kind of a discussion so that there could be a more candid discussion about it. And as far as the this is for people to know, already the credentialing and privileging is already existent in all the NABH hospitals. This is a requirement. This is happening. The idea was that can the privileges be considered in the point of view of tier 2, tier 3 towns? Are we understanding the whole concept of privileging properly? So I think this particular discussion today has opened a lot of, I would say, insight into this entire thing. So thank you very much. Just wanted to make that.
Thank you, Dr. Agrawal. Yes, you have made a very, very pertinent point, commercialization of healthcare, and I think that's a never-ending debate. It may need a lot more time than what we have spent today discussing that. Maybe we will take it up later, maybe next year, maybe sometime during the year. We can have a discussion on that also. Over to you, Dr. Uttare.
Yeah, thank you, Dr. Mangal. I think excellent discussion, and we have heard both the sides. 2-3 just points I would like to make. Number one is a little bit away from this aspect, but which was touched upon, is that investigations being asked when they are not required. Let me just put it down as a person who has worked in the councils as a regulator, worked in a government hospital as a professor of surgery, and worked in a corporate hospital also, which I'm still doing after my retirement from the government. The problem over here is basically because why are we even discussing this privileging is because of some of the judgments which have been given, which has gone against what were the set norms in the past. And because of these judgments of who can do what, that is the reason why I think basically we are having this discussion. And all this has come into play because, nowadays we ask for what is classically called as an evidence-based medicine. And I am a surgeon myself. I am retired now. And I still remember that, something like an appendicitis was diagnosed by my hands and my mind. But today, if there is any problem and it goes to court, the first thing that I am asked was, what is the evidence that this was appendicitis? So, and because of that, I required to do a CT scan, or I required to do at least a minimum a sonography in an acute appendix to prove that, which I didn't require to do around 20 years back, which I was operating just by telling the patient that this is appendicitis. And, let's get away from that. Basically, as far as these credentials, and we have to understand that today the credentials are granted by the state councils. And when the state councils, there was something put forward that how do we do the credentials, having worked for almost 12 years in the council, both at the state level and at the National Medical Commission level. Let me tell you, the state councils goes through all your details, your certification, not only that, if you have done the residency programs of 3 years or not, and after you have done all that, only then the state councils gives you the credentials of getting what is called as a additional qualification certificate. And once you receive that additional qualification certificate, nobody will ask you if you are doing that particular type of procedure or surgery of why you have done that. Now, privileging goes beyond these credentials. Once the credentials are given, you're empowered to do all what as per your whatever your certification is. We are talking about here about privileging, of allowing those who do not have these basic credentials from the state council, but they have the experience, they have taught themselves over years. And as I gave an example in my opening talk, that my teachers were plain MS, but they were teaching urology students, they were teaching plastic surgery students, they were teaching neurology, neurosurgery people of how and what to do. Not only that, they were examiners also for them. But today, as per some of the judgments which have come, they cannot practice as neurosurgeons, urosurgeons, or whatever it is. That is the sad part, and this is where the privileging takes place. Now we have to come to a practical aspect of how do we go about this privileging. I think it is a huge subject, as everybody has said. This is going to take a lot of time in the future also. But as a first step, and this is the first step, is the very fact that we are discussing this. That is the first, step that a child takes towards, walking very straight and then running. So let us not come directly to running, but the first step that we take is, I think, these privileging, and this is what I had done when I was the president of the Maharashtra Medical Council, where there have been, those people who have been practicing this particular oncosurgery, gynec oncosurgery, cardiothoracic surgery. They were doing it for years, but their institution said that since you are just an MS or you are an MD, you are not allowed to do this in the institution. So they came to us in the council saying that this is my experience of doing it. And even in the government service, I have been doing the same thing. Why am I not being allowed to do this in a private setup? And there we took some steps after due discussion in the councils, where we asked them to give their credentials of where have they done this, where have they taken the basic training. If it is there from a institute which has been recognized by the councils, by the MCI at that time. Not only that, we took a letter from the deans and the superintendents of the hospitals in which they were working, that this particular doctor has been doing this oncosurgery for so many years and so many. So it's just like a logbook, though we don't maintain, unfortunately, in India, we do not maintain the logbook. I think that should be made compulsory in the future also, even in your private practice, to have the logbook, because that will tell you if you are empowered to do that particular surgery or not. And taking all this into consideration and discussion in the councils, we have given them a special letter of consent to do that particular oncosurgery or do that cardiothoracic surgery. So I think what we can do is, since the state councils are empowered to give you the credentials, I think the state councils, and this is what I think discussion I will put forward, because I still have contacts in the National Medical Commission, put forward to the National Medical Commission also, that the state council should also have the powers initially for privileging this. In the Western countries, as some of the doctors and some of the judicial people have said, in Western countries, it is the institutions which give this privilege of that particular doctor to do that particular, surgery or procedure. But that may come in the future. And I agree, the ground realities are completely different from what exactly, even in the, I have seen many judgments where the first question was asked, are you qualified to do this particular procedure and surgery? And if not, that doctor has been held negligent. I think that should not be the case, especially in a huge country like India. We cannot afford to have so many consultants and super consultants. Somewhere we have to make some rules and regulations, and that can be done as the judiciary has been saying, that judiciary just interprets whatever the law is. The law has to be made by a central body, and here I feel the central body is the National Medical Commission with the Ministry of Health and Family Welfare. They have to make the rules and regulations where this privileging will be allowed, which is ultimately going to be helpful not only to the doctor community, but mainly to the patients who are there, especially in 2-tier, 3-tier and small villages and small places. So I think this is a first step that we have taken. Congratulations again to the whole committee who have thought about holding this important, deliberations amongst the doctors, the policymakers, and of course the judiciary, because ultimately they are the ones who will be interpreting whatever is put down as the law or rules and regulations in black and white. So thank you, Dr. Mangal, for having called me today. I have learned a lot after hearing to all these, and though I had told you that I may leave by 11:30, I have postponed my next talk, and because it was so interesting to hear all the luminaries over here. Thank you very much.
That was very kind of you, Dr. Utture. Thank you for your kind and encouraging words. That is what motivates us and keeps us going. We have a few questions and comments from our online viewers. I will take them one by one, and if possible, we will try to address them, or we'll keep them posted for some other time. So I start with Brigadier Dr. Ashish Banerjee. He says, Prima facie privilege is discriminatory unless it qualifies the twin test under Article 14, that is having intelligible differentia and a reasonable nexus with a purposive approach. Accordingly, my question is, can we have no fault liability in medical practice in India? One. And the other is, can we have a completely separate forum like CAT to adjudicate medical negligence cases with a panel of doctors as amicus to help the tribunal to have adequate insight in adjudicating complex nuances of medical treatment? Anybody from the judiciary, Advocate Bajpai, Dr. Utture, any answers to these questions?
Yeah, I think before the judiciary gives the final judgment, I think as far as what you said about the tribunal is concerned, this is our demand from the Indian Medical Association also, number one. Number two, excellent, this point you have put forward is about no fault, this, whatever is there. Liability. And that is also what we are asking for many years. And now recently we are asking to get, unless it is really very gross, getting negligence out of the criminalization aspect also, because a lot of things doctors are doing because they are scared of the criminalization. As I said, that evidence-based medicine, we have to prove, like if a patient has got classical symptoms of malaria, today I cannot treat him with the anti-malarial drug unless I have got a report saying that malaria is positive. And medical evidence tells you that almost in 20-25% of the cases, you may not find the malarial parasite, though you are very sure that this is malaria. So if you can get all these things, I think definitely what he said is absolutely right. I leave it to the honorable judiciaries to comment on this. Thank you.
In fact, Dr. Utture, in 2019, we did a convention for the medical tribunal, which was held in Chennai. And if I remember correctly, both Dr. B.C. Gupta and Justice Ravi Tripathi ji were also part of that convention. So we have also been talking about a medical tribunal, which could take care of all something on the lines of an accident tribunal or something like that. So yes, the suggestion does make sense. Let's see how we can proceed with this. There is a comment by Dr. Rukmini Nirmal, and she says, I think competency of a person is decided by three factors. One, education, training, and experience. Sorry, that is education, training, and experience. The doctors immediately after qualification join even a tertiary care hospital. Is that person competent for taking up challenging situations? Like in law, should they gain experience from a competent senior in the field, get experience certificate, and then join the institutes? Second, competency can be assessed by the outcomes of the treatment and feedback. Another issue, in an emergency, any doctor who has the confidence to provide the needed treatment should be permitted to provide treatment without legal limitations. Any comments from anybody here? Justice Tripathi ji, you are smiling.
No, she is right. And I think it's a good suggestion.
Okay.
There should be some training special, because that difficulty we are facing even in our judicial services, where the fresh law graduates are given an opportunity to be the judges. Because then the task becomes a little harder. They have to be given 6 months or 1 year training as a judges. But instead of that, if they have practiced for 3 years or so, and then they are taken as a judges, basic knowledge they will have, and they will be able to perform better even as a judge.
Sure thing. Thank you so very much, Justice Tripathi.
Ravindra.
Yes, Dr. Singh, please.
In the ambit of privileging,
yes,
as the good doctor has brought out, there are two areas which are called FPPE, that is Focused Professional Practice Evaluation. These are all either for new applicants or for new privileges. So in better organized hospitals and accredited hospitals, apart from maybe a few and no discrimination for a few specialties like maybe dermatology, physiotherapy, or something like that, all surgical or interventional specialities do undergo this FPPE.
Okay.
And if there is a new privilege to be added, or he's come after his MS, he's done something else and come to you, then there is an ongoing professional evaluation also, which gives credibility to that. Thank you.
Fantastic. Thank you so much, Dr. Gurbir Singh. I take the next question from Visudha Raj Kaushal. And the question is, can the experience of working in ICU for a few years be used as a privilege for independently managing ICU after MBBS? Should I repeat that? Everybody is smiling, but I don't have any answers.
Ravindra, can I?
Yes, sir, please.
Okay, so yes, this is what many of our speakers have said, including Dr. Utture. He has said that experience should be counted and State Medical Council should be giving up certificates, a very pragmatic way out.
Okay.
That's a suggestion. That has.
Thank you, Mr. Bajpai. For how many years?
I'm sorry.
Sorry.
Sir Mangal, I would like to add to this what just now our lawyer friend said.
Yes.
You know, there, especially this need is very much felt, because I'll tell you, at times what happens is, in some of the hospitals, you have an ICU, there are doctors who are manning the ICU, but say a stenting is to be done. That is done only by the invasive doctor, the head who was to come. And at times, I remember occasions when he is not available and the patient's life is in danger. So at that point of time, you know, if these persons who are there attending to it and they see it every day, they to take these steps, it's required. I mean, they have to be authorized to do that. And I think I just want to clarify one aspect. You know, courts themselves are quite hesitant to proceed against doctors on negligence, especially criminal culpability doesn't come in easily at all. So the cases which come up in courts are very few. And the point that I was making was this, that defensive medicine, contributory factors are there along with this to some extent. Of course, this fear is there. I'll be hauled up. What will happen? Right? But at the same time, there are other factors also, which based on one's own sense of ethics, one will get over with it. Coming back to this, I think there is need for, I remember in one case in Delhi, perhaps all of you would know, for ultrasound, there was no specialized training. There was one doctor on Dhava's Institute and an MBBS doctor from our hospital. He took 60 days training, and after that he resigned from the hospital, and he is now leading ultrasoundologist, so-called, in UP. He does so many of them, and he's been doing them well. So training and expertise you get developed, and after a time with proper tests, they ought to be recognized.
Thank you so very much, Justice Sareen. That's very well articulated. I move on to the next question. For how many years the privileging done for a doctor at the time of onboarding is valid? The next one is, what is the basis on which privileging is done based on the professional degree certificates, background verification? Question from H.M. Divya. Dr. Utture?
Yeah, at present, Mangal sir, let me tell you very frankly, privileging is there in a few hospitals for their own institutions. There is no generalized privileging anywhere. And that is the reason why I was saying that the empowerment should be given to the state councils for getting privilege, so that, you know, they are already doing the credentials, so they can also go one step beyond and be empowered with this also. So there is no question of how many years or anything. That I think that is again a point to be debated. Do they require to, you know, get every few years, 2 years, 5 years? Do they require to undergo some training program or something, so that they can continue with that privilege which is granted to them, which is not basically credentialated by the councils? Yes,
I think Dr. Gurbir also has taken up this point. If you are doing something 20 years back and you have not done it in the last 1 or 2 years, then whether you should be allowed, I think he has already clarified on this point, Dr. Gurbir Singh. Okay, so I move on to a next question, which is very open and very generic. And this, I believe, is from Advocate Preetham Bohraji. Is privilege needed at the cost of patient's health or life?
No, that is the importance of giving a body. See, you can have privileges by self-regulation also, but we are not saying that it should be left to the self-regulation. Here what we are basically saying is there should be some accredited body which should be giving you this power of being privileged to treat the patient in that particular field. That is what is important. So it is not left to the doctors themselves. If you leave that to the doctors themselves to decide what to do, then yes, this problem of the basic health and the rights of the patients comes into play. So you have to balance on both sides the rights of the patients to get treated by a proper doctor who has been given that power by an accredited institution or organization. That is what we are saying. Actually, that is what my
So we are almost nearing the end of our this thing. The last question from
I think Mittal sir
Mangal, I just like to say one thing. Because privileging is very much required actually. Otherwise, doctors will not be able to treat patients with freedom. Actually,
Yes.
it's very difficult. As I while concluding my speech, I also said so. Because what happens is sometimes, like a cancer patient comes to the doctor, then he'll say, "You go to hell. Why should I treat you? Because I'll be hauled up for negligence." Because probability of his survival are very minimal. Unless doctor takes treatment, does treatment for him, it will be very difficult actually. There has to be some privileging that. The question by the advocate probably, because what happens is advocates themselves, if they are specializing in criminal, they would still accept a case for a civil side also.
True.
It should not be there.
True.
So it should, something has to be done. And as Dr. Utre has said, it has to be by a specialized body. Privileging is not done by quacks or somebody sitting there. It has to be by a recognized body only. So doctors have to be given a free hand, otherwise they'll not treat. Only thing is where it is total mere negligence, they should be hauled up.
Sure. Thank you so much, Justice Mittal. We come to the last and final question from Mahavir Gajani. My question to the dignitaries is how to deal with doctors having dual specialty degrees. In such cases, what privilege should be given? Dr. Uttara, I think you'll have to address this again.
I think my experience having dual specialty, it's a very rare thing that we see. Basically, I think what he means is if he is MS general surgery and then does MCH, say MCH neurosurgery, will he be allowed to do MS surgery cases? I think that is what he basically means to say. As of today, as per what the law says, once I give him the additional qualification as MS and as MCH, he's allowed to do both the things. It is left to the doctor to decide what he wants to do. I'm talking from the law point of view because as a counsel, I have given him an credential. I have given him an additional qualification both for MS and MCH also. So he, as of today, he is allowed to do both. So I'm not talking about the moral aspect, as someone said that if I have not done general surgery, say for instance, a neurosurgeon has not touched a hernia or an appendix for the last 10, 15 years, will he be able to do that? That is the mute point for a debatable point which is there, which is left by the August House to decide.
Thank you so very much. On behalf of the Institute of Medicine and Law, I extend my sincere gratitude to all the panelists for having spent so much of time on this wonderful discussion. It has been an eye-opener for all of us here. And I hope to see you again very soon with some other topic, some other subject, or some other program. Thank you very much. It's an honor to host this session. Thank you.
Thank you. Thank you.
Thank you. Very
Thank you,
well
sir.
organized.
Thank you so much. Thank you so much.
Thank you.
Okay, so we are off. We are now off, sir.
Okay.
So should I end the meeting? Sir?